go. Are we good? We are good. Okay, so you guys bear with me here on Instagram because I normally don't stream on you because I didn't have the bandwidth. Now I got the bandwidth. Hello, my friends. Jill Osborne from the wait. Hold on a sec. What happened to my YouTube? Okay. Facebook got started. But my YouTube disappeared. Wait, is that it? Oh, here, hold on. Here it is. Okay, we're live. Okay, you guys, I'm trying something. I'm trying something different. Oh, and I'm sorry for giving you a close-up of my face. Thank you, Mr. A. All right, my friends, Jill Osborne from the Interstitial Cystitis Network. It is Sunday, October 5th. It is time for another live IC support group meeting. Normally I do these on Facebook and YouTube, but today we are adding Instagram. And it is working. I just need to get all my ducks in a row here. All right, because I got to be able to see comments. All right. If anybody's having any issues with sound, please let me know. Hello, Facebook. Hello, you guys. Okay. Deep breath. So I have had a morning. I have been injured. So it's been a crazy weekend here at the IC Network. A huge busy week last week. I'm very happy to tell you that the brand new IC 101 Guide to Managing IC Flares is now completely done. The uploaded, much expanded, double expanded version is now online. I'm waiting for the print drafts that I should get tomorrow. I'm so thrilled with it because we have added yet more from my iteration from last summer. So, oh, Lisa, thank you for the 500 stars, honey. That's great. I really appreciate that. So, what we will be starting tomorrow. Well, so the last thing I'm doing is I'm doing the Kindle. The Kindle is pretty much done. Thanks to technology, it cost me $250, but that's okay. So I will have the Kindle up that this week too. So super exciting. So you guys, when I'm looking straight ahead, I'm looking at Facebook and I'm looking at YouTube, and when I'm looking down, I'm looking at Instagram. Hello, Instagram. So after this crazy busy week, I decided that I needed some sister time. And so I drove up to my sister's house and spent the entire day with her. And we had a blast decorating her house for the fall, all sorts of fun things like that. And I got home, ate dinner, was getting ready for bed when I got an emergency call from my best friend who had been taken by ambulance to the local emergency room. I mean, this just tells you how sudden life can change, right? And she called me on my home phone and I couldn't hear her. Like the call came through at like 8:40. It's like, who would call on a Saturday night at 8:40? So I knew it was important. She had to call back twice because it wouldn't connect to my home phone. Anyway, she had suffered a medical emergency. She had choked on something, couldn't get it out of her throat, had to call 911. And 2 hours later, she's back home. She's good. She's recovering. So if you're watching, honey, I get the reason why I think it's important to talk about this is that it's just so incredibly important that we all have somebody we can call, that we all have somebody that we know will drop everything to come. And that's kind of a theme of what we're going to talk about a little bit today. Normally when I do these meetings, our like first 30 minutes are, kind of me talking about IC, maybe a lecture I might want to do or some health information. And then I'm always happy to take any questions that you might have at all. And so I just, it just reminded me last night as I was driving to the hospital to pick her up at, like 9:30 or whatever time it was, and then getting home about 11, how incredibly sudden life changes can occur. Another person that I'm coming to care for is having his PET scan tomorrow for his cancer. So send me good vibes for that. And then this morning, it's like, okay, I'm home. What am I going to do before this meeting? And so I thought, you know what? I'm going to go take a walk, go walk around the lake, feeling strong, ready to go. Walked up on top of a dam, walking down the dam, and I fell. I didn't do a header on my face. Thank God. I actually fell on there's this wide concrete lip in one area where the soil from the dam has moved away from the walking path. And I just had a rather spectacular fall. Kind of shook me up a little bit, but no blood except on my knee, and I'm fine. But again, yet the other theme of hello, really weird, random things can happen. And I've come to realize about myself that I'm an avoider. Like, I don't know about you, but like if something doesn't go well, I just don't ever want to do that again. And yet as I was picking myself up and people would come make sure I was okay and started walking again, it's like, I'm not letting this stop me. I'm going to go out and walk. It is important for me to walk and to be as healthy as I can. Okay, so yeah, Donna, I'm okay. I have two little cuts on my right knee, and that's it. I'm fine, but my hand is sore. I was just so thankful that I didn't break anything. Travis says, would I mind if you asked advice? Of course not. Go for it. If it's a question about IC and all this sort of stuff, please give me a phone call. I mean, you can text it here. I will answer it here for sure. And then if it's private and it's not something you want to talk about publicly, then you can absolutely give me a phone call too. All right. So bear with me here. I want to try to see YouTube's questions too, which means I have to move things over a little bit. Mr. A says the quality is great and the sound is good. Excellent, excellent, excellent. Yeah, we finally figured out the problem, and it was just kind of a wiring error with our internet. So now we have good internet again. So, okay, so we've got some questions here. So I'm here as long as you have questions. Please feel free to ask any question that you have. Donna says, don't you give me a heart attack. I know. I know, my friend, I know. So for anybody watching, please know for me to keep doing these meetings, I just need questions. Sometimes our meetings will last 5 hours, 4 hours. Sometimes they will last 90 minutes. It all depends upon what's on your mind. Before I take your questions, I want to talk about one of the things that happens when you struggle with something like IC, and that is loneliness, profound loneliness. While your friends are out doing the things they want to do, and believe me, you want to be doing everything you used to do. The challenge for some of us is that you can't go far without having restroom access. And if you're in pain, you can't go take a long car ride because the car is going to hurt. And what I found for me, so remember, my IC hit, oh, Debbie, we'll talk about that in a moment. Hold that thought. My IC began at the age of 13. I had frequency urgency in 13. I'm 65 years old now. I've got all of you beat on how long you've had IC, I'm sure. I've had it for a very, very long time. I am almost completely symptom-free now, and I have been symptom-free for many years. My symptoms began, though, at a time of life when you're supposed to be making friends. You're supposed to be socializing. You're supposed to be going to parties and looking for partners and all that sort of stuff. And that was very difficult for a little girl, a young teenager, who all of a sudden had to go to the bathroom all the time. Didn't know why. I didn't know why. Nobody knew why. Everybody thought, Jill's got an infection. Just got an infection. And they treated me with antibiotics. They gave me a lot of urethral dilations, and in the end, it didn't work. And so all of a sudden, those school field trips, which should have been fun, were torture sessions of embarrassment because my mother had to talk to the teacher about stopping the bus to let me pee. And then in high school, and I guess the other thing for me is that I also was a victim of a really severe adverse childhood event because I was a victim, and I was attacked when I was in 4th grade by a young man who later became a rapist and a murderer. And I did not leave my home without fear for a decade. And in my brain, in my child's brain, the loneliness was so profound because people didn't fight for me. Kids didn't walk with me. And it's funny, we do our high school reunions and we have our victim reunion. I'm not the only one. And the year I went away to college, he raped and murdered my neighbor. Okay. So, we're talking really serious mental illness here that left me terrified and left me running for my life. And in my brain, I will tell you very, very honestly, my self-identity for the vast majority of my life has been as a little redheaded girl running home as fast as she could to get away from the scary guy. And I have a master's in psych, guys. I have worked with, hold on. I don't know what's going on with YouTube. With Instagram here. It faded out there. Hello, you guys. Let me wave back. It said I wasn't using it, but I am using it. Do I have to say things? Here, I'll just say hi. Okay. So when you have been a victim of abuse, the loneliness is even more profound. And then throw in the medical conditions that happen because of abuse and because of injury and because of trauma. I find so many of my sisters and my brothers who also suffered abuse and challenges when they were younger, and how that affected them and affected me our entire lives. A lot of people say, Jill, why aren't you married? And why don't you have children? Well, I always thought I'd have children. In fact, I thought I'd have 5. I will tell you very honestly, it is very, very difficult for me to trust because I have been hurt profoundly. Came close twice, came very, very close, but just didn't happen. And the other thing too is that when you're in the gist of this, whether it's migraines, whether it's irritable bowel, whether it's IC, whether it's vulvodynia, the harsh reality is that you're at home and you need to be at home. You need to be able to eat the food you would normally eat. Going out to eat at a restaurant, not fun when you've got IC. And the thing is, a lot of socialization happens around meals, and all of a sudden for us, can we go to that restaurant? Hard to say. So I get and understand the loneliness because sometimes I feel like I have been the queen of loneliness. And yet I know I'm not lonely because I see friends that I've helped for many, many years. And I love it when people call me and they say, hey, Jill, I first talked to you 30 years ago. And it's like, yeah, baby, we're still here. We're still doing it 30 years later. But I have to work hard to break the loneliness. And that's what I really want to remind you of, is you got to work hard to break your loneliness. And this means you've got to get out of your house. You got to go for walks. You got to meet your neighbors. You got to say hi to people. Whenever I walk around the lake, I say hi to everybody. And I've had great conversations. Whenever somebody's walking a dog, I always say, you have a gorgeous dog. And I end up having a nice discussion with them. because I know that to go the day without talking with somebody is not well for me. I have to have interaction. I have to have people near me. I don't like being alone. I don't like feeling lonely. And so we have to, on a daily basis, work to change that. It's very easy for people to say, join a club. Yeah, there aren't a lot of clubs right now, to be quite honest. But so what I did is I went to my neighbors, and I have one neighbor in particular who's got stage 4 prostate cancer. And I said, hey, man, how you doing? He was struggling. I said, okay, when you need to get out of the house, come to my house. Come to my house. Let's play games. And you know what? We have a blast. And so then I put it out on Nextdoor to a bunch of other people. Anybody out there with any medical conditions? You feeling lonely at home? Let's do games. And you know, nobody is responsible for our happiness but us. We're the ones who have to look at the day that we're leading and ask, what can we do this day that will give us comfort and joy and companionship? Thank you, hun. Good community to play games. Yeah, and you know, like, so a lot of us, well, some of us played online games for a while, like Fortnite. Had a blast doing that. I was a raid leader with World of Warcraft and a guild master for World of Warcraft for quite some time. That was a way to meet people. But like, I want people in my home. I want people that I can laugh with. I want people too. So if or any of you out there are in Northern California or you're coming my way, would you please send me a note? Because you're welcome to come over and play games at my house too. I just think we can't walk away from each other. Now, in my walks about 2 weeks ago, as I was walking through the neighborhood, I met this sweet little elderly lady who was sitting on her walker out in front of a home. And she showed me her book of art she was drawing. And she didn't speak English well. She was Asian, lovely, kind, sweet lady. And so I stood with her for about 30 minutes and I let her show me everything that she'd drawn. And as I walked away and, I waved to her and she waved to me and I could see that she was very lonely. She too was lonely, even though she had family. It was clearly she needed to be outside to meet others just like I did. And I thought, gee, I wonder if I can give her a painting set because I do a lot of painting. I like really, really complex adult paint by numbers, like professional grade paint by numbers that are really, really intricate. Like you got to use a magnifying glass to paint. And I had a couple extras and I drove by there this morning and her grandson was out and I pulled over and I talked to him and I said, do you have a grandmama that's staying with you? And she goes, yeah. And I said, I met her and she was delightful. And I asked if I could give her something and I did. I went home and I grabbed a couple of things and drove back and gave it to them because they were caring for her. That's the way you make friends. His name was Jack. My dad's name was Jack. Instant connection. So please, please, please don't let IC isolate you. Yes, there are going to be moments you're going to be home. There are going to be moments on the holidays when you want to go do things and maybe you can't go do those things. But IC doesn't say anything about you as a person. It doesn't reflect in any way about your soul and your spirit. It is below the waist. Keep it there. You cannot let this change your self-esteem. You have done nothing wrong. You are worthy to be loved. You are a good friend. You are a good mother. You are a good father. You are a good daughter, sister, brother. IC cannot and does not change any of that. So I don't want you to go into a self-imposed exile because of this. There is nothing for you to be ashamed of. You just got hurt. I was working with a guy who called me last week who diagnosed with IC. IC therapy is not working, yada, yada, yada. He had not had the single most important diagnostic test for a man, which was a pelvic floor assessment. He's like, why would that affect my bladder? I explained why, that tight pelvic floor muscles cause ischemia, which causes the bladder wall to break down. So I taught him the science. We went through the science. And I'm like, okay, let's see if we can figure this out. Can you remember any traumas? He's like, no. But then he gave me a really, really big, giant clue. He's like, I'm a weightlifter. Oh, that's all you need to say. And then, you kind of nuance the symptoms a little bit. Okay, where's the pain? Well, the pain's centered, but it's also over on the left side. And I'm like, okay, the bladder's not on the left side. So now I got to figure out what's on the left side. Hello, pelvic floor. Talking with IC patients is like threading a needle or looking for a needle in a haystack. If you know how to ask the right questions, we can usually do a good phenotype workup. We can usually figure out what is happening here. Hold on, I got to keep Instagram functioning here. Now, I don't see things here. Hold on a sec. Donna says, you always bring me joy. I'm getting emotional, Jill. You know how special you are. Donna, honey, we are spirit sisters in every way. Hold on a sec. Look at all you guys. Slee says, I got the Axonics bladder pacemaker about 4 weeks ago. I learned when you're sick, your body is inflamed. I guess it does not work. Well, honey, it all depends upon what your phenotype is. Remember, the way we treat IC is we don't want to chase the symptoms. We want to find and identify the underlying cause and fix the underlying cause so you don't have the symptoms in the first place. So we have to understand what your phenotype is first. Do you have Hunner's lesions? If you got Hunner's lesions, a nerve stim is going to do nothing. Do you have estrogen atrophy? Not going to, it might slightly modulate some of the symptoms, so it's not going to fix the estrogen atrophy. Do you have chemocystitis? Not going to fix chemocystitis. Do you have tight pelvic floor muscles? Well, nerve stim is not nearly as effective for tight pelvic floor muscles as just hands-on physical therapy. Yeah, pudendal neuralgia, maybe in that case, InterStim might be a little bit helpful in trying to downregulate that nerve a little bit. And then, of course, if you've got widespread pain, central sensitization, it's not going to do a damn thing because central sensitization is all about the central nervous system. Right. So the thing about anytime you have a device put into your body, you got to be really aggressive with your doctors. You got to be really aggressive in tracking your symptoms, reporting if it's not working, because if it's not working, you want to get it out. You want to get it out. You don't want to just leave, foreign matter inside your body. The longer it's in there, the harder it is to remove. But the question is have you been tracking your symptoms well enough to actually see if it's helping or not? So if your frequency was 30 times a day before you had it done, and now it's 20 times or 15 times a day, that means it's working a little bit. So how are you tracking your symptoms? Okay, a lot of you are asking to be in the video, and I don't know how to do, I don't want to do that quite yet. Let's see here. Who knew YouTube? Who knew Instagram would be so big? All right, hold on. Iram says, hi, everyone. I've had IC for the past 16 years, managing it okay, but sometimes I feel so sad about not drinking coffee or being able to keep weight down as it feels inflamed. Okay, so what do our guidelines say? Our guidelines say if you're not responding to therapy, if you're getting worse rather than better, take a step back and revisit the diagnosis. What could we have missed? Did they miss something? If bladder therapies aren't working, or if you have a healthy bladder wall, then maybe this is not bladder wall driven. Maybe this is pelvic floor driven. The point here is you've had it for 16 years, but you're still struggling. And we want to figure out why you're still struggling. I can drink stuff now. I can drink lemonade every day now because my bladder has healed, because my muscles have healed. Mr. A said, back when I had IC or what I suspect was IC, my symptoms were bad during the day, but strangely, I was able to sleep through the night. Does that suggest my bladder was healthy? Isn't that interesting? Let's think about that for a moment. That I would consider that a really rare presentation in any IC patient, because IC is most commonly known, the bladder wall is most commonly known for causing nighttime frequency urgency. And so you didn't have any nighttime frequency urgency. That's really unusual. So, Mr. A, the next question that I would ask you is, when is your pain the worst during the day, before you pee or after you're done peeing? Because that then would give us a clue as to whether we're dealing with bladder stuff, or more importantly, maybe we're dealing with muscle stuff. Now, another thing, but you're a gentleman, and I don't think that's just, pelvic congestion syndrome occurs when there's a varicose vein in the pelvis. And what happens is patients sleep fine. They get up in the morning, they're fine. But as the day goes on, they get a sensation of heaviness and pressure that gets worse and worse and worse and worse throughout the day. And then by the end of the day, dinner time, they feel like they got a bowling ball around in their pelvis. Many have been diagnosed with interstitial cystitis with these symptoms. We never really understood what this symptom was until the last 5 or so years, because that actually is a symptom of pelvic congestion syndrome. And then, of course, when they lay down and the blood distributes throughout the rest of the body and is no longer pooling in the pelvis, all their symptoms go away. They sleep great. And then as soon as they get up the next morning, it's the same thing, just pressure, pain throughout the day. They're very frustrated. They go to sleep. It's all good. And then it revisits. So let me look at something here real quick. Hold on a second. So the thing here is that I don't know to what degree men can get something like pelvic congestion syndrome. Hold on a sec. Let me just see if this book says anything about that. Okay, page 34 to 35. The book I'm looking at this is our book, Facing Pelvic Pain. This is the book for anybody where, like, literally your bladder's perfect, bladder therapies aren't working, really nobody knows what it is. This book is kind of like a master class in all the other conditions that can cause these urinary symptoms. Okay, hold on. What was the page number again? Let's just see here real quick. Okay, 34 and 35. Sorry, I know I said that before. I just went to 54 and it wasn't there. So pelvic congestion syndrome is a term used to describe dilated veins in the pelvis that cause a pooling of blood in pelvic organs. This is similar to varicose veins found elsewhere in the body. Classically, the pain is aching, throbbing, pressing, or camping. It increases with periods, occurs with prolonged standing, with sex or orgasm. It occurs most often in women who have given birth. So they're not saying anything about men getting that. I mean, so that's like one condition where I can think of that symptom happening. We could dive into the research and see if we can find something else. All right, let me go here to Facebook. You guys, so again, I'm on 3 platforms, so just bear with me as I jump to each platform. Do not be offended if I don't answer your question. Please be the squeaky wheel and just keep asking it until you get my attention. Anne said, so if you have E. coli in your culture and you always treated with antibiotics, I want to retest. How long should I wait after I'm done with the antibiotics? Maybe a week or two. Travis said, what sort of advice do you have for vulvodynia? I've struggled with it for a few years and I haven't found anything for relief. Would estrogen gel help? Okay, so Travis, vulvodynia means that we've got pain in the vulvar area. That's just vulva, dynia. Dynia means pain. There are many potential causes of vulvodynia. The very first thing we're going to look for is there a chemical irritation of the vulva, like from mini pads or from spermicide or from condoms. We're going to look for irritation maybe from laundry detergent, maybe from fabric softener. We're going to look at the quality and health of the skin. Is this patient in estrogen atrophy from being on a strong birth control or being on Lupron for endometriosis or on a estrogen suppressor because of breast cancer? Hello, my fellow breast cancer patients. Hello, I'm part of you. It sucks. Or are you just getting older? The quality and health of your skin matters. When you lose estrogen, your skin gets drier. It doesn't have the mucus it needs to protect itself, and it starts to hurt. You know how dry mouth hurts? Well, guess what? So does dry vulva. Dry vulva hurts. So that's one thing we want to look for. We want to look for infections. There can be an infection of the vestibular gland. That's something that a doctor can do a Q-tip test on to see if we've got any issues with the vestibular gland. But most importantly, we want to look at the health of your pelvic floor. Because when you have tight muscles, they squeeze the nerves that go to the vulva and the vulva starts to react. The vulva gets very, very inflamed. So I had terrific vulvodynia in high school. I got to tell you, I felt like I was having a yeast infection every day. I had some days where I could not wear underwear, although I did at school, but I was miserable. As soon as I got home, I had to pop those suckers off and wear a lot of long dresses and skirts. Vulvodynia is brutal. And again, it feels like the world's worst yeast infection. And yet when the doctor looks at your skin, it's like, Jill, I see nothing down here. You're fine. And I'm like, then why does it feel like I have a horrific yeast infection? And his answer was, you just have the most sensitive skin I have ever seen. But here's the thing for my vulvodynia. My vulvodynia was the worst on my perineum. That little inch of skin between your vulva and your rectum. Holy hell, mother of God, did that sucker hurt? It was bad. Again, it just felt like somebody was scrubbing it with an SOS pad, or steel wool. It was so painful. Finally got the answer to that. The answer to that is that immediately above the skin of the perineum is something called the perineal body. The perineal body is a little attachment point for, this is a good example right here. Muscle here, muscle here, muscle here, muscle here. Right in the middle, look at that. There's a little round thing that all those muscles attach to. It's called the perineal body. And guess what? If your muscles are pulling, that perineal body hurts like hell. Perineal pain. So I now realize that all the vulvodynia, we should have had stock and Monistat. My God, think of the millions of women who treat themselves with Candida, Monistat, Miselex, things like that, because they think they have a yeast infection, which I did many, many, many times. And in hindsight, I now realize that I was having pelvic floor spasms that were pulling the perineal body, which was giving me that perineal pain. And ironically, I would, when I was in high school, I would come home afterwards and I would sit in a hot bathtub for 30 minutes. And that was the only thing that helped. And of course, heat relaxes muscle. So vulvodynia is a real thing. I have a lot of information on vulvodynia on our website, but more importantly, in our new flare management guide, the flare guide, I have a section on vulvodynia flares. So you can get the PDF version of this right now over on the IC Network website. I will have the print version next week. PDF is $9.99. It's 80 pages. Some of our best work. I wrote the very first IC Flare guide 10 years ago. We're finally updating it, and I've quadrupled the size of it. Okie dokie, artichoke. Let's see what else we had. Debbie said, had her innerstem removed. You fell and walked the battery so hard. You hurt the battery when you fell. So now what do I do for frequency urgency? So, all right. So Debbie, so we're now back at trying to understand what your phenotype is. We have to understand what's driving that frequency urgency in the first place, because all the innerstim did was it covered it up, didn't fix anything. We got to try to fix this. We got to find the underlying problem and try to fix the underlying problem. Okay, Donna, I'm going to let you in, but I don't know what you're going to do with this. So, because remember, I'm streaming elsewhere. So nobody's going to hear you. At least I don't think they are. Okay, so Debbie, we want to go back and we want to try to understand what your phenotype is. What is your phenotype? Frequency urgency is controlled by the alpha afferent nerve. Hold on. My tonsil. It's a legacy of my tonsillitis. Hold on a sec. If I talk too much, I get a needle poking in my left tonsil. So it just happened. But anyway, I'm okay. Okay, so frequency urgency is going to come from the alpha afferent nerve in the bladder wall. So we now have to try to figure out what is irritating that nerve in the first place. Is it going to be food? Is it going to be estrogen atrophy? Is it going to be a chemical irritation? Or is it going to be tight muscles? So if you can, go over to the IC Network website, watch episode 4 of our IC 101 masterclass, and then give me a phone call. I'd be happy to talk to you about it. Okay, hold on. I'm okay. I promise you I'm okay. Hi, Carlina. I am recovering from the most horrific bout of tonsillitis of my life. And I'm way better, but my tonsils are still a little on the tender side. I might have to go gargle with salt water. We'll see. My eyes are red. Look at that. Oh. Okay. It's always something. Lisa said, Lisa is home after 22 days following having her bladder removed. Lisa, welcome home, my friend. Welcome home. How are you doing? Hi, Sherry. Hello, Johanna. Sue said, my whole world was my business, which was at my home, my children. I'm caring for my aging parents. Empty your nest, and now the kids are super busy. Parents have passed, and now with long COVID and painful bladder, I have to force myself to get out of the house. I'm still grieving, though. It's only been since March. Yeah. You know, I was not prepared for how traumatic grief is. Hello, you guys. Hello. So for those who just came in Instagram, my name is Jill Osborne. I'm the president and founder of the Interstitial Cystitis Network. It is Sunday afternoon. Every Sunday, I do the only live IC support group meetings in the United States, if not in the world at this point in time. I mean, there might be one other, but we've been doing this for many, many years, Sunday afternoons. Normally it's on YouTube and it's on Facebook, but I got my internet fixed and I'm trying Instagram too. So right now we're streaming on 3 platforms. So when I look up, that means I'm looking at the other platforms. And if you've never been to the IC network before, the IC network was the first website ever built on IC. I built it in 1994. 31 years ago, we have been rated the best, most accurate, reliable website that entire time in peer-reviewed studies, including a study done by the University of London and a study done by Harvard. I'm very, very proud of what we have been able to accomplish, especially before social media, because before social media, I had 200,000 patients a month that we were working with on our website. And then social media came and people kind of scattered to the wind, and that's okay. It's okay for people to scatter because we got plenty of stuff doing. In addition to doing IC support, I'm an IC researcher. I also write a lot and participate in a lot of international IC stuff. I also appear at medical conferences around the world and things like that. So, but fundamentally, my job is to give you hope. Hello, Foothill Physical Therapy on Instagram. Do you do pelvic floor work? What's so incredibly cool now is now I can remember, I think it was 2008, 2007, when Rhonda Cotterinos came to the first NIH meeting on IC. And here was this physical therapist walking into a room full of urologists who was saying, so guys, have you ever tried working with the muscles? And they blew her off. They just absolutely blew her off. And she's like, I want you to know that I'm working with pelvic pain patients. I'm working with IC patients. And when we work with their muscles, they feel better. They do better. So please consider working with their muscles. And of course, the problem with Western medicine today is the doctors play in their sandbox. It's very hard for them to go beyond the bladder. You go to a urologist, they're urinary tract. You go to a gynecologist, they're the reproductive tract. They don't necessarily look at the relationships between these organs and structures, the relationship specifically with muscles and with nerves and with blood vessels. And so anyway, she was just an inspiring, but also just very purposeful, strong woman to walk into a room dominantly of arrogant men and said, hey, guess what? Here's something you might have missed. She came back the next year, the next conference, and they gave her an opportunity to speak to the conference, but they gave her the last session of the day, if I remember correctly. And so half of the audience walked out and didn't listen to her. And we were there. I was there. It was outrageous. But the wonderful end result is, through her courage and perseverance, the National Institutes of Health funded an IC study, an IC physical therapy study. It was a multi-center study. That study proved that pelvic floor physical therapy absolutely worked for 70 to 75% of the patients who had it done. If I remember correctly, I think that's a stat. And that was the moment the IC world was turned on its head, because up to that point, everybody's going bladder disease, bladder disease, bladder disease. And then we have this physical therapy study come out that showed it worked far better than any bladder therapy that had been studied to that point. And everybody went, oh, how would muscle work fix a bladder disease? And then you throw in the fact that most of us have normal bladders anyway. I'm one of them, but my muscles were so messed up. They felt like concrete. They were so tight. And anyway, the blessing now is that we have thousands of physical therapists who have taken classes and working with the pelvic floor. We have physical therapists that are fully certified in working with pelvic pain, pelvic floor conditions. And we also have physical therapists who have taken extra coursework so they can work with men, because men need as much help as we do, if not more. And so it's wonderful to see physical therapists being vocal and telling their success stories and sharing their challenges and getting that training. We now believe, and this is a common assessment if you go to any conference, that the front line of IC care is no longer the urologist. We now believe the front line of IC care for the great majority of patients is actually going to be the physical therapist. And I was talking with one of the top IC researchers in the world and his wife, who's also an IC researcher, about a month ago. And what did she say? She said, what did she say? She said something like, physical therapy has become the new Cipro for urologists. It was very, very interesting. Very, very interesting. Okay. Johanna said she tried Femitry. It only worked for a few days. You're almost done with a 60-pill bottle. Okay. What, now listen, nothing really happens in a couple of weeks in the bladder. The bladder is the slowest healing organ in the body. It takes 2 weeks for one cell to be replaced. So doing something for a month is not really giving your bladder a fair shot of healing, which is why all the bladder therapies say, they really want you to try it for about 3 months. I would say 6 weeks at a minimum, ideally. But you shouldn't be powering through side effects. If you're having horrific side effects from anything, then that medication or supplement is probably not for you. But again, 1 month, it's just I maybe give it another couple of weeks and just see how you're doing at a minimum. Johanna, starting physical therapy tomorrow. Fingers crossed that it works. Good. Now, Johanna, I want you to be able to know the names of the muscles so that as they are doing their pelvic floor assessment, you will know exactly what structure they're touching. There are 3 layers of muscles in the pelvis. They're kind of equivalent to your index finger. So you've got shallow muscles, your levator ani muscle. Then you got a layer of deeper muscle and obturator, and then you've got, mid-level muscle, and then you've got the deep muscle, which is like the piriformis. So when you go to physical therapy, they're going to assess your muscle tone vaginally by touching muscle groups on your left side and your right side, shallow and deep. And if they can touch a muscle and trigger your pain, that is what I call your hallelujah moment. That's super exciting. And that's when you say, oh my God, that's it. What are you touching? Because if you have tight pelvic floor muscles, I want you to be able to walk out of that appointment knowing the name of the muscle that's tight. And this is especially true if you cannot afford consistent physical therapy. If you walk out and they say, okay, you've got a tight piriformis on your left side, write down the name of the muscle. Ask the physical therapist for suggestions. Be really honest that you've got financial limitations and you cannot come every week because your insurance won't cover it. But ideally, maybe you can come back in 6 months if you have a chance to do what they suggest that you do and or watch videos on YouTube that might help you understand how to rehabilitate your specific muscle injury. But that's not going to be nearly as effective as somebody working directly with your body. Fingers on muscles, fingers on your body, hands on your body. Travis said, who would I see for a pelvic floor exam? You would see a physical therapist, my friend. I'm pretty sure the primary cause of my vulvodynia is testosterone injections I take for medical transition, but unfortunately, stopping the testosterone is not an option for you. Physical therapist. If you go to pelvicrehab.com, that's short for rehabilitation, pelvicrehab.com, that's one of the best lists you can find of physical therapists trained in pelvic floor work. Travis says, cannot wear underwear. It's so humiliating. I always remove my clothes immediately when getting home, and I isolate myself in my bedroom so I don't have to wear clothes. So long skirts, my friend, or kilts. Do a kilt. Or just put a robe on. Or just, listen, wear flannel pajama pants. I mean, the point here is we just want a lot of air between your bits. And so flannel pajama pants would be okay, although the texture of the flannel might be irritating. So maybe linen or maybe a soft cotton jersey or modal. But that's one way to deal with that too. All right, so here, hold on a sec. Let me go over to YouTube. Hello, Lisa, my friend. Lisa, you talk about tight pelvic floor, but you have a weak pelvic floor. I've been going to pelvic floor therapy, which has helped tremendously. My urologist told me to find a support group, and I found you. Yay! I'm so glad you did. Okay, so we have to ask ourselves, why is that muscle tight in the first place? What has happened to make that muscle tight? Because muscles by nature are generally soft and pliant, and they're only tight when they're working really, really hard. Like if you were weightlifting, that would be a way of tightening muscles. Or when you pop a bicep, that obviously tightens that muscle right there. So a healthy muscle feels like a raw chicken breast. It's soft, but it has substance. A tight muscle feels like a cooked chicken breast, kind of a rubbery chicken breast, not a lot of give. A badly damaged muscle feels like jerky, beef jerky. So at some point in time, something happened which made your muscles tight. So it could be, for example, if you rode a horse or rode bicycles for a lot of time, that pressure of the bike seat or the saddle up on the pelvic floor, that puts a lot of strain on that muscle. That can be tight. But we often see a lot of injuries falling on your tailbone. So or falling downstairs. Oh my God. So many of you guys have fallen downstairs. You'd be amazed at the number of patients who that has happened to, especially on your tailbone. So here you land hard on your tailbone or your crotch. That's what we call a crush injury. All of your weight is landing on a small spot, maybe a 4-inch by 4-inch or 3-inch by 3-inch spot on your glute, on your butt muscle, on your tailbone somewhere. And what does that do? All your weight presses down on the muscles. It squeezes the muscles. It presses down on the blood vessels, and the blood vessels break. That's why you get a bruise. Whenever you have a bruise, that's a broken blood vessel. See, look, I got one today right here. See that? That's from my fall on my walk today. Okay, and when you fall, you also can fall and injure nerves. So a compressed, damaged muscle is essentially a broken muscle. It is a weakened muscle. That muscle has been structurally compromised. But that muscle still has a job to do. It's still like your piriformis still plays a role in stabilizing your SI joint. And so it's because that muscle is weaker, it has to work harder to do its normal job. So it has to compensate. It compensates for the weakness by getting tighter. So one of the questions we always want to ask the physical therapist is, are your muscles responding to therapy, or are they always locking back down into tension? If your muscles, no matter what the physical therapist does, are always tight, like me on my left side, my pelvic floor on my left side is very tight. We have to look beyond the muscles at what puts stress on the muscles, which is bones. And for me, it's my SI joint. My SI joint is hyper flexible. My muscle locks down super, super tight to keep that joint in play. And that's something that I always have to work on. Until I can get that fixed, I'm going to be struggling. Hello, you guys on Instagram. So my name is Jill Osborne. I'm the president and founder of the Interstitial Cystitis Network. We're doing an IC support group meeting right now. We're streaming it on 3 platforms. So when I'm looking here, I'm looking at Instagram. When I'm looking over there, I'm looking at my YouTube members. And when I'm looking here, I'm looking at Facebook. All right. So if you have questions, please feel free to ask your question. So physical therapy isn't just about relaxing muscles. It's about helping weak muscles get strong again. But the question is, you just have to go about it in the right way. So let's say you've got a very weak muscle that's very, very tight. Well, you don't start with Kegels, because the problem is your muscles are already super, super tight. What the physical therapist is first going to do is to help get that muscle relaxed and released. Once we got that muscle relaxed, then we go back in with strengthening to try to restore normal muscle tone with that muscle. So there's a very specific sequence of events that has to happen when somebody has tight but weak muscles. And please just don't start doing Kegels. You're going to hurt yourself. Here, hold on a sec. Jessica, I have bladder pain syndrome. I've had it since I was 8 years old. It's really hard. Girl, me too. Generally, when symptoms begin at a very, very young age, the very first thing we're always going to look at is the role of trauma. Was there a physical injury in childhood, like being hit by a car? I can still remember a gentleman that I was working with who had severe IC. He was in his 50s. And it all began when he was badly hit by a car when he was in elementary school. And he had a catastrophic pelvic injury, just catastrophic injuries from the entire accident. And even though the bones had healed, etc., his life had been haunted by all these symptoms of IC. What we didn't know back then that we know now is that pelvic floor muscles after trauma are often the root cause of a lot of our symptoms. And so when we do that hands-on physical therapy and when we try to restore normal muscle tone, that will only help. A lot of patients have been stuck with very, very, very tight muscles for decades. And if you're one of those patients where like you've never been able to have sex without pain, I mean, there are some women and men who cannot tolerate any penetration at all. Good luck getting a finger in there, a doctor getting a finger in there. It's impossible because their muscles are like this. And the reason why their muscles are like this is often related to trauma in childhood, especially sexual abuse in childhood, but it can just be a major physical injury too. So, Jessica, it would be really interesting to know what your phenotype is. We have phenotypes now. Our goal now, I mean, we don't tell patients they all have incurable bladder disease anymore. That's just not true. Today, we call IC a pelvic pain syndrome, for which there are many potential causes. Our job is to figure out what your cause is. We don't want to chase the symptoms. We want to identify the underlying problem and fix the underlying problem so you don't have the symptoms in the first place. And we've learned terrible lessons recently about keeping patients on medications that are not working for them, like Elmeron, because now we've got patients who are going blind and have inflammatory bowel disease. So Debbie says here, and you guys, if I miss anything, just keep asking the question until I answer it, okay? Debbie says her doctor wants to do Botox now. I'm tired of all this nonsense. Well, I mean, Botox can be diagnostic. Botox can kind of be like a nerve block. Again, we have to try to understand underlying anatomy here. So what does the doctor say the Botox is going to do for you? Botox silences nerves temporarily. It turns off nerves. So if they can turn off the nerve that controls your frequency, urgency, or pain, then you would walk out of that Botox feeling great for a couple of months. And then slowly the Botox wears off, and then you have to have another one. The challenge with Botox is it's very random in a way. With Botox, they're going to inject different points of the bladder wall. And their goal is to hope that they have found the nerves that will control frequency urgency. But sometimes they silence a nerve that gives you the ability to empty your bladder. And so one of the adverse events of Botox is urinary retention and not being able to pee on command. So there is a risk with Botox you have to be aware of. Hi, Carlene. Hello, my friend John. Debbie says grief is a chronic condition. Absolutely. Lori asks, how do I feel about Botox for the icy bladder? The role of Botox for an icy bladder has gotten very, very small now. Very, very small. Tammy says, I'm living on azo, been on antibiotics for 4 months. I can't stand this. Okay, so Tammy, you've been on antibiotics for 4 months. Clearly, at some point in time, somebody did urine testing and they found infection, right? So the question is, what infection did they find? And what is the drug resistances involved? Because antibiotics for 4 months is fairly extreme unless you are a recurring UTI patient. So tell us what your urine testing is. Diane said, I'm doing sacral neuromodulation trial now. It's improved her urgency some, but frequency during the day is still 12 to 15 times. I did have a couple of better nights. We're going 3 to 4 times instead of 5 to 7. I have the I have the InterStim trial removed tomorrow morning. And the surgery to permanently implant the next day. I'd like more time to decide, but the doctor's scheduler says he's booked out for the rest of the year. I want it done this year because I've met my deductible. Well, you have to have a successful trial before you go for permanent implant. I don't know if you can classify that as a successful trial. I mean, your frequency's gone down a little bit at night, but not during the day. I mean, you're going to have a really blunt discussion with your doctor and say, okay, here's my stats. Would we classify this as a success or not? I don't know if I would classify that as a success. Kelly on Instagram said, you've been taking Elmeron for 16 years with good success. Does that tell you anything about the type of IC you have? So Kelly, yes, it does. So Elmeron is the equivalent of a Band-Aid. It's a chemical coating of the bladder wall. So what that means then is that your bladder wall needed protection. So the question is why? Why would your bladder wall needed protection? Are you an estrogen atrophy patient? Did this begin when you were going through chemotherapy? Are we dealing with some chemical injuries of the bladder wall where it needed some protection? Your phenotype really matters here. So Dr. Parsons, the guy who invented Elmeron, appeared at the 2006 San Diego IC conference, and somebody asked him, will I have to take Elmeron for the rest of my life? And he said, no, you just have to figure out if it's helping you or not. So how do you do that? What he said at that conference is you just reduce the dose. So if you're taking 4 a day, what he said is go to 3 a day for a week, see if your symptoms change. If your symptoms get worse, then maybe the 4 a day is more beneficial. But if your symptoms don't get worse, maybe the Elmeron's not helping as much as you thought. So he said, go down to 2 a day. See how you do. And again, if your symptoms get worse, then okay, it's helping. If they don't, go down to 1. Of course, this was well before we knew the risk of Elmeron to your eyesight and to your bowel. I mean, we have patients now who have gone blind and lost their bowels at the same time. The adverse events of Elmeron are now substantial and quite serious. And so in the old days, we all, believed that this was a fairly safe medication. But when you actually look at the adverse events file, there are like over 5,000 adverse events with Elmeron in the FAERS federal database. 3,000 of them are related to eye damage. And then I think 800 of them are related to bowel damage. One of the things, Kelly, I would encourage you to consider is if you've had a colonoscopy recently, when you go to get your colonoscopy, one of the things that they're now finding is carpet polyps, that we're seeing polyp development, dozens of polyps appearing throughout the bowel. And you know, polyps come in different shapes. There are some polyps that look like mushrooms, so they've got a stem and then they've got a structure on top, again, like a mushroom. Other polyps are flat polyps, and the flat polyps are the ones that are known for becoming or creating a greater risk of bowel cancer. Well, the carpal polyps that they're finding in these ICers using Elmeron are the flat polyps, and so we now have patients who have had to have colectomies to remove those. It was actually the researchers at the Emory Eye Institute who found the retinal issues, who later coalesced the data regarding the bowel issues. And now we have a lot of research on that. We have a lot of case studies on that. And I think, people say, well, how? How? Well, we now have two very, very, very strong theories. And the first thing is that if you go back to, I think, 2004, 2005, you will see case studies of patients with IC taking Elmeron who developed severe colitis, severe symptoms, that when they stopped it, it went away. And I have all those studies over on the IC Network website. I've got an article called The Tragic and Tarnished History of Elmeron. Every single one of those studies is listed. You can look at those studies. So it's like, okay, clearly, if you stop the medication and the symptom goes away, maybe the medication is causing that symptom. And then what the researchers, and I don't remember which research, it was probably somebody, Emory, in one of those papers, what they found is that the chemical structure of Elmeron, pentosan polysulfate, is actually quite similar to a chemical used to deliberately damage tissue, specifically the bowel, for research papers. And so they think that it's just a chemical that can cause injury or trauma. And again, that's kind of what we see in the bowel. We see a lot of inflammation and irritation. And most interestingly, just a month or two ago, we have our first published paper of another medication that is considered a sister to Elmeron that is also now linked. I don't remember if it was eye issues or it was bowel issues, but anyway, they made the point that the molecular structure of the medications were very, very similar, and now we saw these adverse events with this new medication too. So you got to be careful. Been taking it for a long time. The longer you take it, the greater the risk. And what the research shows is that the damage progresses even after you stop it. So there goes my left tonsil again. Let me go get a drink of water. I'll be right back. Sorry about that. A little hot water with Manuka honey. You know, I have I have days when I literally talk straight for 6 or 8 hours because that's my job is I work with patients on the phone. I do just a massive amount of coaching these days. That's why you don't see me online hardly at all anymore. It's because I'm working with patients. And my I think that that's why my tonsils are so vulnerable because I can be in the middle of a conversation and then it's like a needle is being poked into my tonsil, and it's always my left tonsil. Okay. Lori says, and you guys, if I missed a question, just answer it, ask it again. Do not be offended. My eyes are all over the place. Lori says, if the problem is pelvic floor, would aloe not be beneficial? No, it really wouldn't be. Aloe's role has gotten very, very small now. 30 years ago, 25 years ago, it's all we had. I mean, we had Cistro Protect and we had aloe, and that was it. But there is not a single published study in a medical journal that shows that aloe is helpful for IC or the urinary tract in general. And in fact, let me just qualify that because studies come out every day. Let me just take a quick look. I'm going to the National Library of Medicine. Hold on, and let's see. Okay, the National Library of Medicine is PubMed. My mouse keeps disappearing. Let me try this computer. I sit in front of a lot of computers. Okay, hold on. All right, so I'm at National Library of Medicine, pubmed.gov, and I'm going to type in aloe interstitial cystitis. Nothing. Okay, so let's type in aloe bladder. Okay, we have a study in 2006 with not related to aloe. Here's somebody, they're talking about aloe vera for treating bladder cancer. Here's a study in 2024. Oh, this is interesting. The evaluation of a 90-day repeated dose oral toxicity of an aloe vera inner leaf gel beverage. So this is a study that found in rats that there was not an established toxic effect to an aloe beverage for 90 days, but it had nothing to do with interstitial cystitis or anything. Okay, guys, just know. They were just trying to say, are aloe drinks safe? And this study said it looks like they're safe if the aloe has been processed correctly. Okay, hold on. Here's a study, acute inflammation and hematological response in Nile tilapia fed a supplemented diet with natural extracts of propolis and aloe. Here's one on pancreatic cancer in hamsters. Here's one on schistosoma mansoni infections. Oh, that the researcher's. Oh, I get it. The researcher's name is Aloe. Oh, that. So wait a second. Hold on. 1, 2, 3, 4. Okay. So there's only 6 papers that obscurely reference aloe in the bladder, but they're really more for in the treatment of cancer, pancreatic cancer, things like that. So again, so our role for aloe has gotten very, very small. I think, because remember, the bladder is not made of aloe. Aloe is soothing. If you have a sunburn and you put aloe on the sunburn, it feels good. It's soothing. I'm good with that. If you're having a bladder wall flare, like you had a couple cups of coffee and your bladder's screaming at you, that's the time to take a little bit of aloe. But I don't think that the long-term use of aloe makes sense for every IC patient because we have phenotypes now and it's all about your phenotype. Aloe's not going to fix anything. It's not going to fix tight pelvic floor muscles. It's not going to fix a Hunter's lesion caused by a virus. It's not going to fix chemocystitis. It's not going to fix estrogen atrophy. It has its window is just as a soothing effect. So there are other things that I think are much more beneficial, like palmitoyl ethanolamide, PEA for pain. I can give you dozens of studies that show that taking PEA will reduce pain in a lot of medical conditions, including IC. The IC study with PEA showed that 87% of IC patients reported a significant progressive reduction in pain over time. Listen, if you got pain or you're in the chronic overlapping pain condition, widespread pain phenotype, the supplement we're going to say as a first line of thought consideration is going to be Peora or pea leaf. That's what I take. I have a healthy bladder. There's nothing wrong with my bladder. I am a pelvic floor widespread pain patient. I have to treat mine with working with my muscles and calming my nervous system. PEA has been stunningly successful for me. If you have Hunter's lesions, we're going to look at lactoferrin, because we've got a great research study with lactoferrin making red inflamed bladders pink and healthy and Hunter's lesions virtually disappearing. So anybody with profound inflammation in their bladder, the lactoferrin's worth a shot. Now, there's a lot of lactoferrin on the market. There's cheap lactoferrin and there's expensive lactoferrin. There's lactoferrin that comes from cows, we call it bovine lactoferrin. There's lactoferrin that comes from laboratories where it's a bioidentical, they're making it. And there's also lactoferrin that they get from people. Now that lactoferrin is hundreds and hundreds and hundreds of dollars, and that's creepy. I think that's a little bit on the creepy side. So we don't want to do cheap lactoferrin because a lot of cheap lactoferrin, in my opinion, is going to come from China, or it's going to come from cows that are potentially exposed to bird flu. And I'm certainly not comfortable with that. The lactoferrin that we have in the IC Network store, which is the one that I introduced the IC patient population to, comes from Australia, where there's no bird flu. And that's the same source of lactoferrin used in the IC study. Now we've got the emergence of bioidentical human. Some people are calling this human lactoferrin. It's not human, it's made in a lab. And there's just always pros and cons to everything. The bioidentical lactoferrin also is extremely expensive. So you're going to see companies selling it for $90, $100, $150. The bovine lactoferrin is going to be in the $40, $50, $60, $70 range. And this is not for the rest of your life. And with the IC study, they did it for 4 months. And we saw red inflamed bladders become pink and healthy, and Hunter's lesions almost completely disappeared. So that would be an interesting thing to consider too. So again, let's look at the research. The Oxford Scale of Evidence-Based Medicine is a scale that we use to evaluate information online. You know, when I started the IC network, again, this was before social media, we had a giant forum, 50,000 members. That forum's still on our website, not used that often, but that's okay. It's a huge archive of information. And I couldn't make anybody happy. I mean, I cried a lot the first 5 years of the IC network because I had people coming into our forum saying, hey, you can cure yourself by drinking the juice of a lemon, or hey, you can cure yourself by, sleeping on magnets and this and that and this and that. And then I caught sales reps pretending to be patients. And it's like, no, you work for the company, don't you? Yes, we do. Then why are you pretending to be a patient? I mean, we caught so many salespeople trying to sell stuff. It was just infuriating. So I was on the phone with the guy who ran the IC research program at Ohio State, and his name is escaping me right now. Kind of crying, going, what do I do? What do I do? And he goes, Jill, you use the Oxford Scale of Evidence-Based Medicine. Like, what's that? He goes, that's how you rate the information you get online. Okay, what's that? An F, the least reliable source of information, is somebody selling something, or the opinion of another patient. That's an F. A D is the opinion of an expert, not supported by a research study. A C is a preliminary study, a B is a better study, and an A is a double-blind placebo-controlled study. So when we think about how tight money is right now, I don't want you to, like, I had this sweet little elderly lady call me, and she had just run out of money. She was paying a ton of money for Elmeron. She emptied her retirement. And she called me and she said, what do I do? I have no more money. And I said, did it help? And she said, no. She'd been on it for 10 years. Like, did it help? No, never. I'm like, then why did you keep taking it? Why did you throw your money away? And her answer was that her doctor had nothing else for her. And I will never forget her because she was terrified for her future. And that's why today we don't want to throw our money away on something that doesn't have at least some research showing that it's specifically helpful for IC or for bladder pain or for Hunter's lesions. And so, again, the chondroitin-based supplements, the Cistro Project, I got research with that. That works. The lactoferrin, really good study with that. PEA, dozens of studies with that. Aloe, nothing. Nada. Okay? And I double dog dare you, go over to National Library of Medicine, pubmed.gov, put in aloe and interstitial cystitis or aloe in the bladder, and you can look for yourself. Travis said, a kill could certainly work as I'm actually from Scotland. Love it. Joanna says, it doesn't help that I have terrible constipation. Constipation is a sign of tight pelvic floor muscles. Michelle said, I don't have physical therapy available in Fort Smith, Arkansas, and I can't drive very far. Any ideas? Well, let's look real quick. All right, so we're going to go to pelvicrehab.com. And where are you from again? Arkansas, Fort Smith, Arkansas. Let's see what they say. This is a database that you can search by zip code. There are 2 in Fort Smith, Arkansas, my friend. There are 2 in Fort Smith, Arkansas. No, there's more. 1, 2, 3, 4. There are 5 physical therapists in Fort Smith, Arkansas, who have taken some of the pelvic rehab classes. Not all of them, but some of them. Okay? So there you go. Go to pelvicrehab.com and put in your zip code. Anne says, if you have E. coli in your urine, do they always treat or only with symptoms? Depends upon how much E. coli you have, honey. Lori says, Botox has helped my overactive bladder, which in return helps my muscle spasms. Cool. Hey, Kayleen. Lori says, where would I get more information on phenotypes? Over on the IC Network website. I have an IC 101 video series masterclass. It's episode 4. Hi, David. David said, what is the other medication that is similar to Elmeron that is doing damage? Let me look. I think I can find that fairly quickly. Hold on. So again, I'm going to PubMed, my home away from home, and I'm going to do Pentosan. Let's see. We'll do Pentosan Retina. Maculopathy. I put it in my magazine. Hold on. So this is our latest IC Optimist magazine. This is where we do our best work. This is our 23rd year of doing our magazine. It goes to our members. So I think I put it in here. Let me look. Let me see if I did or not. Page 27. Did I put it in here? So the latest research in here is we have a new bladder coating like Elmeron, but not with the damage of Elmeron that they're studying in Australia. We have the first human study showing success with 72% of patients reporting moderate or marked improvement. So we do have things in the pipeline that will coat the bladder like Elmeron without the harm. They're testing a chemotherapy drug with urinary symptoms. They're testing placenta growth factors. Interesting study, how do we stop fibrosis in the bladder wall? Researchers from Japan sought to reduce inflammation in the bladder by inhibiting a specific growth factor. And they work, okay. Anyway, they're testing different medications, and one medication with a bunch of SB 431542 reduced damage and lessen thickening of tissue in mice. It might be a therapy for IC. Oh, and this is important. We had a new research study from Wake Forest, Dr. Robert Evans' team. They sought to determine if IC was progressive or not. Because back in the day when I was diagnosed, the general assumption was this appeared to be progressive. It's not. So researchers at Wake Forest, one of the premier IC research centers in the world, reviewed the progression or lack thereof of IC symptoms in 221 patients over time, evaluating bladder capacity under anesthesia, the presence of Hunner's lesions and or glomulations on the bladder wall. The goal was to understand how patients change over time. They found that the great majority of patients did not experience a change in their bladder capacity. A very small group of patients, 16 out of 221 or 7.2%, mostly with Hunner's lesions, did experience a decrease in bladder capacity over time, while another group, roughly the same size, showed an improvement in bladder capacity. So they quoted, most patients that undergo multiple hydrodistensions do not experience a significant change in their bladder capacity over time. Isn't that interesting? Okay, so I did not put that one in my magazine. So let me see if I can find it here real quick. Ocular involvement of West Nile virus? Why are you giving me that? There's a study from July, the rapid progression of maculopathy after pentosan polysulfate cessation. The 75-year-old woman. Here, hold on. Presented with macular degeneration and progressive blurring of her central vision beginning at the age of 69. An exam revealed pigmentary maculopathy. She'd been on Elmeron. She started at the age of 63 and stopped at the age of 71. So she was on it for 8 years. 4 years post stopping the med, her eyes had progressed terribly. So they concluded BPS maculopathy is an acquired toxic disease that can significantly impact a patient's quality of life. A report highlights the marked progression of pentosan retinopathy that can occur even after drug cessation. Yet another reason to move on from that treatment, potentially. Okay, still looking for this chemical. Wow, there's another one. And another one. God, look at all these papers. Wow. Here's somebody 10 years after stopping it. Okay, so let me try AI. What medication has been linked to pigmentary maculopathy? Similar to pentosan. It's not coming up easy. I know I read it. Oh, okay. So hold on. New medication. I'm sorry, guys. I'm trying AI. Linked to retinal damage. Similar to pentosan. 2025. Here it is. One is called Blenrep, known for a high rate of eye damage. And then the other one is GLP-1 receptor agonists. We're talking Ozempic, linked to optic neuropathy, macular degeneration. So it's semaglutide and tirzepatide meds are linked to eye conditions. I knew we'd find it. Donna said, how's Dr. Evans doing? I talked to him a couple weeks ago. They are now in the camp of thinking that he has a long-term COVID blood clotting disorder. So Robert Evans is a top IC clinician in the country. He practiced out of Wake Forest for many, many years, voted the best doctor in the country every single time we ever had a vote. Absolutely beloved by most of his patients. Great, like 99.9% of his patients. Sweet guy. last January, he started having very severe pain in his legs and arms. And it was blood clots. He has a condition of blood clots that are moving through his extremities. Now, the scary thing about this blood clotting disorder is it's often linked to pancreatic cancer. So they thought at first that he might be coming down with cancer, but all of the cancer testing was negative. They have found no sign of cancer in him. So, and he cannot walk and stand comfortably. He can't, I mean, he can't do surgery or anything, which is horrific because he's probably one of the best surgeons for IC in the world, certainly for bladder transplants in the world. So they are now of the opinion that this is a blood clotting disorder related to COVID. So he's still trying. He's trying, my friends. He's a good man. I just had another email from him a couple days ago. John, I got to talk to you. All right. Hold on one sec. Let me go over to YouTube real quick. Kelly said, the only thing that stops my urethral bladder pain is by drinking 3 bottles of ice water in the morning. Medicine and pelvic floor therapy didn't help. You were diagnosed with IC 16 years ago. Pain is unbearable most of the time. Kelly, I'd love to talk to you, girl. I would love to talk with you. If you would give me a phone call this week, our 800 number is on the top of our page. You know, you're suffering, and we need to try to figure out how and why you're suffering. I mean, so drinking, so what immediately comes to mind is the fact that when you massively dilute your urine, your pain gets better. So what that means then is that there's something in your urine that's really irritating the hell out of your bladder. And or that your bladder wall is vulnerable to urine for some reason. So we're dealing either with chemocystitis, or we're dealing with something going on with your bladder wall that's making your bladder wall more vulnerable. Or it could even be something as simple as dehydration, or even something as simple as taking a multivitamin every day. My God, I was just working with another patient who had the dreaded flare after starting these new mass market silver vitamins for older people. So I'd love to kind of brainstorm with you and ask you a bunch of really challenging questions to see if we could narrow this down a little bit more. Then my job is to give you a new set of questions to talk with your doctor about. I'm not your doctor. I don't give medical advice. I educate, I inform, I try to open some new doors. Then you send you back to your doctor with a new set of questions. Hello, Instagram. And the fact that your pain is unbearable, I want to learn a lot more about that pain. Where is the pain located? Is it to the left, to the right, centered? Is it shallow? Is it deep? What makes it better? What makes it worse? We can learn a lot from that. Yeah, please call me tomorrow. That would be great. And Lisa said, Lisa K, again, I had to pop off for a bit. Didn't know if you commented on my post. I did, honey. You'll have to go back and watch. So basically, a muscle becomes weak because of some sort of injury or trauma, but it still has a job to do. So that muscle then gets tighter to do the job more effectively. And so therapeutically, the first thing we have to do is we got to release the tight muscles. Once you release the tight muscles, that's when you start strengthening muscles again. You guys are working me today. Michelle said, I'm new to interacting here. You guys, I'm really delayed on Facebook. Thanks for sticking out, waiting for me to answer your question. I'm new to interacting here. I feel pelvic floor therapy could help me immensely. It is excruciating to have intercourse, and I need something in my area for pelvic pain. What can I do instead? Is there something I can learn to do myself? I have dilators, but they are plastic and quite hard and quite painful. Michelle, You cannot figure this out on your own. You have to have a professional study your muscles first. So if that means having to drive an hour, it's worth driving an hour. If it have to drive a half an hour, it's worth there. But the fact that intercourse is excruciating tells us that we've got a fundamental problem down there. What has your doctor said about that? I mean, the number one reason why intercourse would be excruciating, of course, is going to be tight pelvic floor muscles or severe dryness. But is there any chance you have a prolapse? Is there any chance you have a fibroid? Is there anything else going on that would make sex so painful? What does your gynecologist say? Kayleen says, Happy Breast Cancer Awareness Month. Yes. I'm a year and a half post my breast cancer diagnosis. The girls are gone. You see that? I got nothing. It's very weird, my friends. Because what you don't realize is that when you have breasts here, it hides your tummy folds. Now that I'm flat, I've got a tummy here I never knew I had. Oh God, you know, the things. And listen, it was brutal surgery. I'm still recovering from the surgery. I still have tremendous pain at times from this surgery. So I'm not making light of it, but I'm just so grateful that we caught it. Get your mammograms, my friend. They found mine with a routine mammogram. And it was stage 0, thank God, but it was definitely cancer. And my only treatment was to have the breast removed because it was far apart. I wasn't eligible for a lumpectomy. And so I decided to have both breasts removed because I didn't like having 38D and double D breath that I'd had. But cancer is it's very traumatic, and I don't want you to go through what I went through. Now, let me just say this. I asked my oncologist, why me? There's no breast cancer in my family, none. And she said only 15% of breast cancer is estrogen dependent. For the rest of us, it is environmental exposures combined with periods of very, very intense stress and also sugar consumption because cancer feeds on sugar. And I had been caring for my elderly parents as they were dying. And my stress level was off the charts. Y'all saw it. I was doing these meetings while I was doing it. You saw it and you met my parents. They would walk in. My dad made it to 100. My mom made it to 94. I did not understand the toll that had taken on me because I got diagnosed with high blood pressure, having arguments with my 100-year-old dad who wanted to drive and I didn't want him to. And I didn't have a night away in 7 years. 7 years without one night away. The stress was ridiculous. So if there's anything that I can say to you right now, it's don't live in stress. We got to all listen, our society right now, our country right now, the world right now, social media right now is all being driven by keeping us angry. That's how they make their money. That's how social media makes its money, is to keep pushing upsetting things, because when you're upset, you engage. When you're happy, you go walk. They want to keep making money. And the way they're making money is by keeping us all upset. This is so unhealthy. Please, please turn it off. There are people who just want to fight. Let them fight. I don't need to bring that into my home. In fact, it's crazy. My favorite authors, J.A. Jance, had a new book that just came out. And I got it. And it was about a murderer. And I'm like, I read the first chapter and I went, I'm not reading this. I do not need to spend time reading about a murderer. I have to take responsibility for my mental health. And that's what we all have to do right now is please bring the stress down. Don't live online. Ask yourself every day, what can I do today that would make me happy and that would make my friends and my family happy? and then go do it. And that's not being online, and that's not playing computer games, and that's not debating politics. Just, they can all have meltdowns. I'm not bringing that into my house anymore. I'm done. I have deleted YouTube from my iPad. Obviously, I work on YouTube. I'm on YouTube right now, but I don't need to watch any more political stuff. It's harmful to my mental health. And I've been through enough with cancer and with all that other stuff. I mean, I am I am, a lot of people say you're so strong. And you know what? I am strong. I'm very, very strong, but I'm hurt. My soul has been hurt going through this. And my job is to try to heal my soul and my spirit. And all I know is that's not going to be online. So I want you to, I don't want what happened to me to happen to you. I really don't. Diane said, I'm wondering if the new implantable tibial neuromodulator is effective as a sacral neuromodulation implants, but much less expensive and invasive. They have a new one out called Altaviva from Medtronic. PTNS has helped me with urgency, but I don't like to go in every month. They were invented at the same time at UC San Francisco 31 years ago. I was a patient at UC San Francisco. I was in the ankle stim group. I had ankle stim done. I'm very grateful I had ankle stim done rather than the early days of InterStim. It is much less invasive. They have exactly the same FDA approvals. Definitely go with the ankle first. It's cheaper. And the risks of adverse events are tiny when compared to the risks of adverse events for InterStim. Johanna said, I work at Ohio State University Hospital. Who was the guy? His name was Tony Buffington, and he's now out here at UC Davis. Tony Buffington. And he actually, so he worked with the only animal model of IC, which was in cats. And his research, he was in all the big human IC studies. Fabulous guy. His insight into IC is amazing. One of the things he taught me with his research, because cats also get interstitial cystitis. And so you have a cat that's straining to pee all day and they look horrific, and there's no, it's not minerals or stones. It's literally a cystitis condition. And a lot of these cats are euthanized. They're euthanized. So they ended up bringing a lot of these cats into their veterinary clinic at Ohio State. And what they learned is that when you put this cat in a safe environment that is warm and safe with no stress, their symptoms go away. But if somebody strange walks into the room and that cat gets scared, their symptoms came back. So that's a really good example of how stress can affect the urinary tract. Stress is bad. And when we as people or animals live in a state of constant, intense stress and fight or flight, that amplifies pain throughout the body, that amplifies nerve sensitivity throughout the body. Okay, so Donna and Denise, you guys are trying to be in the live video, and I don't know what that's going to look like. So we can try it, but if you can, I mean, Donna, I know and I trust 100%. Denise, I'm sorry, I don't know you. And since we're streaming on other platforms, I got to be careful with what might be said. You don't, oh, Donna says she doesn't want to be live. Okay, then let's not do that. We can go into Zoom. If anybody wants to go live at the end of this meeting, we can just go into Zoom and hang out. And if you guys have questions, you can ask me one-on-one and you can be live on camera. Kayleen said, is my physical therapy going to be mad at me for not using my wand? In my defense, I didn't find out about this UTI until I was getting transvaginal ultrasound. You got to work on it, honey. You have to work every week on improving your muscle health. Cece said, is mushroom coffee a good option for patients? I don't know. I honestly don't know. I've never tried it. I have no clue. All right. I feel like we've lost stuff. All right. Let me go back here to YouTube. Lisa says, I've been consciously watching what I eat and drink. I've noticed citric acid soda pop causes irritation. The pre-leaf has really helped. Good. Oh, that makes me think of soda pop, K-pop Demon Hunter. The Saja Boys soda pop song is so good. It's so good. I love listen, I'm 65 years old and I love K-pop Demon Hunter. I could watch it every day. It's just guys, and last night, for anybody who likes K-pop Demon Hunter, on Saturday Night Live, they actually brought in the 3 singers for Golden and for the female song for the girl group for Huntrix. And they sang live on Saturday Night Live, and they didn't sing the whole song. They sang part of it, but apparently they're going to sing the whole song on Jimmy Fallon this week sometime. I don't know what day. What's so cool about that is that the singer who sings lead, who plays Rumi, was in the K-pop system for 10 years and didn't get accepted by any group. And so now she's in her, I don't know how, I mean, she might be in her like mid to late 20s. And she got denied by like every K-pop group. And now she has like some of the best songs ever. And her voice is wonderful. So anyway, I'm a huge K-pop person. And BTS, I can't wait for the next BTS song and BTS album. Hardest working band of my lifetime is BTS. Oops. I'm a nut. I know I'm a nut, but it just makes me happy. Disney makes me happy too. I just want to be happy. All right. Donna said, what is the feedback regarding all the new supplements? I'm using P-Leaf and I like it. Donna, would you please go put a review on Amazon for P-Leaf? That would be great. So our first PEA supplement, Peora, has been out for 4 to 5 years. I took that research to that company, Natural Approach Nutrition, and asked them to make a supplement that was close to what was used in the study. They did. It's Peora. It's used by thousands of patients now. I use it myself. And P-Leaf is an exact match of the study formula done by the same company that makes Pre-Leaf. One of the challenges that we've had is that people have been confused by the name. They think P-Leaf, P-E-A-L-I-E-F, is like Pre-Leaf. And so people take it thinking that it's going to help them eat food, and it's not the same thing at all. So there's a lot of name confusion here. So Pre-Leaf helps to reduce acid in food. P-Leaf is a palmitoyl ethanolamide supplement designed to reduce pain. You can get it on Amazon, but you're going to notice it's got a couple of 1-star reviews on Amazon. Well, they all have. I mean, nothing's perfect out there. I actually talked to one of the people who gave it a 1-star review, and she thought it was for eating food, and that's why she gave it a 1-star review. But P-Leaf is absolutely a viable option. Okay, my ear just started ringing. Stop it. So anyway, I think that the future of supplements, in my opinion, I mean, so I think the best days of aloe are kind of done again, because we just don't have any research showing that helpful for IC, et cetera, that's published in any peer-reviewed medical journal. I think that the future is PEA because it calms nerves down and reduces pain. And we've got research with IC, we've got research with menstrual cramps. That's a newest study. We've got research with pelvic pain in men, research with prostatitis, research with shingles, research with fibromyalgia, etc. The safety profile of PEA is really second to none. The vast majority of studies show no adverse events, no known drug interactions. The IC study with PEA showed that 87% of patients using it reported a significant progressive reduction in pain. It's not a pain med. It's not an opiate. It doesn't cause addiction or anything at all like that. It acts to calm nerves down. Now, Donna says she loves Pura. Yeah. So, Denise said, has anybody tried acid-free coffee? Girl, we've been selling acid-free coffee for 20 years in the IC Network shop. Tyler's is one, but let me show you the one that's the best in lab studies. So hold on a sec. Where is it? Let me find it. Bella Rosa. Huh. It's not on my shelf. It's called Bella Rosa. Bella Rosa. Low acid coffee has the lowest levels of chlorogenic acid in the industry. It's a chlorogenic acid that's responsible for the acidity. So coffee acidity is determined three ways. It's determined by the altitude the bean is grown at. The higher the altitude, the higher the acid. It's determined by how it's roasted. If it's roasted in a hot metal drum, as the vast majority of coffee is, the contact with the hot metal and the coffee bean produces the chlorogenic acid. Okay. Denise is PEA leaf, not PEE, PEA leaf. And then the third way the coffee acidity is determined is by how you brew it. A hot brewing method extracts more acid from the bean. A cold brewing method extracts less. So again, altitude, roasting, brewing. So the lowest acid coffee is going to be a low altitude coffee like Bella Rosa, roasted, air roasting, which is how they do it, and cold brew. So we sell a ton of Bella Rosa coffee. The other thing I like about it is they have regular, decaf, and half calf. So we don't recommend any regular coffee because it turns nerves on. It just exacerbates nerve sensitivity. But for those of you who have been addicted or you need that little bit of caffeine, you can do their half calf, which is half the irritation at least. And then going for the decaf is the way to go. So Bella Rosa coffee, go over to icnetwork.org, click on shop, and we have a whole section on coffee. We've sold all the low acid coffees at one point in time. I mean, that's like I used to go to food shows looking specifically for low acid coffee. And so we have Bella Rosa, we had Tyler's, we just discontinued that. And then we had, what's that one? Simpatico. You can get Simpatico in some stores. Simpatico is a nice low acid coffee, not as good as Bella Rosa. Euromild, which comes out of Canada, they have a great low acid coffee there too. And there are some others too, but in the end, I think, and what my customers think, is that the Bella Rosa coffee, low acid coffees are the best coffees. low acid coffees and the great flavor profiles too. And also too, for those of us who cannot do any coffee, listen, coffee is my happy place. If I have to evacuate in a fire, my safe harbor is at a Starbucks. And I lived on Frappuccinos. I would get a decaf Frappuccino with just a little bit of pumpkin spice or a little bit of cinnamon dolce, whatever. But my heart has gotten so sensitive now because I had a horrific reaction to COVID vaccine and it affected my heart. I can't touch it with a 10-foot pole. And so the only coffee I can do is Dandy Blend, which is an herbal coffee that we sell, which is really good. Let me go in fact, I was going to make it live during the meeting. Hold on a sec. Let me go get it. Okay, so if you're craving a cup of something hot, but you can't do the coffee or the green tea, of course, if you have a sensitive bladder, you go to Dandy Blend. So Dandy Blend is an herbal coffee. It's called Dandy because it has dandelion root in it, and dandelion root is actually kind of sweet. Most herbal coffee is really bitter, like Ticino. Oh my God, trying to swallow that without sugar is very, very difficult. So Dandy Blend is the first herbal coffee that I've ever had that didn't make me want to spit it out. It's mellow, it's gentle, but it has a really good earthy flavor. And the crazy thing is, one of the things that I used to love about coffee is that if I felt constipated, you could drink a cup of coffee and usually 30 minutes later, you're done. You've been able to go to the bathroom. Same thing happens with Dandy Blend, which is very interesting to me. So what I had in here, this is my Dandy Blend from this morning. So I filled this up, microwaved it with hot water all the way up to about here, like about an inch from the top, or a little, maybe an inch and a half from the top. Teaspoon of Dandy Blend, stirred it up. And look at what I got online. I got this simple syrup, this pumpkin spice syrup. It's an agave syrup. So I used a little of this. I do tend to use a little bit of sugar, which I'm annoyed with because sugar makes cancer grow, but they say they got all my cancer, but it's fall, it's cold. And I don't know about you guys, but I'm cold all the time. My dad used to complain about that. He would wear polar fleece in the middle of summer, and I would always laugh at him. Now I'm my dad. I get cold all the time, so I want something hot. And then I've got pumpkin spice, just topping that you put on top. Put a little bit of mocha mix in there or your whatever creamer you do. There you go. You got a bladder-friendly pumpkin spice latte. And you don't have to do pumpkin spice if you don't like pumpkin spice. Caddy says Fabula low acid does not bother. I've never heard of that brand, Fabula. I'll have to check it out. Okay, hold on a sec. Let me go back here. Johanna says, what are the hours to be able to call me? I would suggest that you call after 10 Pacific time. I'm usually back from the gym by like 9. Because I try to go to the gym every morning now. And that's Pacific time. So I would say from 10 a.m. till 5 or 6 Pacific time. And if you don't get me, just leave your name and number and I'll call you back when I can. Uh-oh, do I have something on my lip from that? Okay. That's funny. Now, y'all would tell me if there was something wrong that made me look stupid, right? Somebody would go, Jill, you got something on your face, right? That's how I met my best friend in high school. I walked into class, our first day English class, and my mascara was down under my eyes. And she looked at me and she goes, have you seen your face? I was like, no. She goes, your mascara is all over the place. Go fix it. She's been my best friend for almost 50 years now. I was so grateful for her making sure I wasn't embarrassed for the rest of the school day. In fact, she was the one I was at the hospital with last night. Shelley says, I've replaced regular coffee with mushroom coffee without any irritation in my bladder. I use Rise. I will have to get some and try it. What does it taste like? William says, do we know anything about how marijuana affects IC? Okay, so William, we have the longest running study of marijuana with IC on the IC network. I think it's actually still open. If you go to the ICN Survey Center, might be, it might not be. I don't remember, but I mean it was open for at least 6-7 years. Our study found that many patients use marijuana very successfully. They preferred edibles over smoking, did not exacerbate their symptoms unless they were using medical marijuana that had been contaminated with pesticides. So quality matters, the source matters. So medical marijuana, if it is a viable source and legal in your state, would be reasonable, but you would do a CBD medical marijuana, not a THC medical marijuana. So it's CBD, the cannabinoids that block pain receptors. The THC is what gets you high. So you want high CBD. Now, the other thing too is that CBD from hemp is legal in every state. You can get it at freaking Walmart. So you can try hemp CBD also. And the bladder has CBD receptors in it. So CBD is absolutely viable. Let's see here. Lori said, I'm struggling. I'm in pain since April. You just finished your 6th installation with no relief. I can't get the burning and spasms to stop. Okay, so Lori, have they looked in your bladder? So burning and spasms. So there are a lot of questions that I'd like to ask you about that. So the first thing I want to know is, where is the burning? Is it inside of your body or on the outside of your body? So is it on the inside or the outside? If it's inside of your body, where specifically is it? Is it in your urethra? Is it in your vagina? Or is it in your rectum? So can you answer that? And then also, okay, so let's just go with that question, because if we were on the phone, this would be the first question that I would ask you, is where is the burning? Is it on the inside or is it on the outside on your skin? So let us know. Diane said, I also want more time to decide on the permanent sacral neuromodulation implant because I forgot to complete a pre-treatment bladder and bowel diary. Oh, honey, no, oh, no. Lesson learned. How are you going to evaluate if it works if you don't know where you're starting? Oh, shoot. I understand. She said that she's having some family challenges with some family members. Oh, girl. And you fell and you bruised your tailbone. You're in your backside. Well, because of the tailbone roots, I decided to push back my trial implant for 3 weeks. So you forgot all about you doing the pre-treatment diary. I was so stressed with everything. It's been hard to think straight. Honey, I want to give you a hug. I want to give you a hug because I know that you're very angry with yourself. It's just stop it. Don't be angry with yourself. It is what it is. You're going through stuff. I'm so sorry about your daughter. And I truly think you're doing a wonderful thing being with your granddaughters right now while your daughter is going through what she's going through. You have a real challenge here. Because at this point in time, we have no way of knowing if that's helping or not. And you've got to be really blunt with your doctor about this and just say, listen, I don't know if it's helping or not. I want to say this in the right way. Getting back to the Oxford scale of evidence-based medicine. Like there's 2 different ways that you can look at this. You can look at this, number one, with the doctor saying, oh, let's do it anyway, just in case. And is just in case a good enough reason to invest all of that money and surgery and, most importantly, risks? Because there are a ton of risks with InterStim. There are hundreds, thousands of adverse events filed with the FDA with InterStim. And so you got to have your eyes wide open here. So I'm uncomfortable making a decision based upon maybe it might help. The other challenge here is that, listen, the doctor takes the vow, do no harm. And I want to give every doctor the benefit of the doubt that they are always, always, always thinking of the patient before they're thinking of themselves. But InterStim is a moneymaker. They do make more money when they do surgery and they do implants. So we cannot throw out the fact that there is a little financial incentive to encourage you to do it, especially if they're telling you to do it quickly. You know, it's like buying a car. It's like, okay, you kind of like this car. Here's your deal. You can have it. If you make your decision in the next day, we'll give you this price. You know, and people apply timeline as a pressure to encourage decision making. So Diane says, if I could have time after they take out the SNS for a week and then could track your symptoms. I think that that's completely reasonable what you're asking for. Diane, listen, it's never my job to get between you and your doctor, ever, ever, ever. They're the ones who give you medical advice. I cannot do that. So my job is to give you new questions that you can ask your doctor. And so I think that I would ask, do we have the data that shows that this is helping me? And can we make this decision to do the implant without that data? And if the doctor says, well, we don't really have data, how do you feel? You've got to be really, really blunt. I'm not sleeping any better. I might have a little bit here and a little bit there, but it has done this for me. and be super honest and just say, okay, this is how I feel. Because when you make this commitment, this is not a one-day commitment. This is a months-long, serious financial commitment. A lot of doctor's visits. You're having at least 2, if not more, invasive surgeries. So I think the data really matters here. Uh, one option would be, if you want more data, is you can have it removed and you can wait until next year and do it again. And be honest with the doctor and just say, listen, I'm under a massive amount of stress right now. I have a child that's in distress. I'm responsible for caring for grandchildren. And then you have to ask yourself too, can I care for my grandchildren with surgery? Because you're not going to be able to lift them and do things like that for a period of time. This is surgery. So I don't know if you have enough information to make that decision. I just don't. Okay, guys, listen, my phone is I'm going to have to go get my charger. Hold on a sec. I'll be right back. Hold on. All right, hold on. I got to find a plug. There we go. Okay. All righty. Oh, wait a second. Wrong plug. Let's do this plug. Yes, we're trusting this computer. Oh, God. Okay, we're good. Woo! What a day. What a day. Okay, let's get back to Lori here. So I asked Lori a question. Where is her burning? So they looked in her bladder. Her bladder was very inflamed. Okay. And she's had relentless burning for a period of time. So let me go back to Lori here. Okay. So I asked her the question, where is the burning? Inside or outside? Her burning is in the urethra and on the outside on her vulva. So Lori, how old are you, hun? How old are you? Because that, my friend, is most likely estrogen atrophy in your urethra on your vulva. Okay. So it starts, she's 52. That's when it hit me at 51, 52. All of a sudden, I had urethral burning and irritation. Oh my God, it made me crazy. And listen, my IC skills are obviously very, very good. I threw everything I knew at this new urethral burning that I had. Nothing worked. Nothing worked. And it was just getting worse. And so I finally threw myself on the mercy of my urologist, and now realize I ran this. I'm the only support group leader that was sponsored by Kaiser Permanente, and so I ran support groups at their hospital for a decade. They had never seen me cry. They had never seen me do any of this. So anyway, so they're like, Jill knows her stuff. It's okay. So I make this appointment. I go in, please help me with this urethra burning. It's so bad. So imagine I'm laying on my back, my feet are in stirrups. He is looking down there, and I'm looking at him through my knees. You're going, okay, doc, what do you see down there? He goes, Jill. I'm like, what? And he goes, didn't you use the estrogen cream I gave you last year? And I went, no. And he said, why? And I said, because in my brain, I'm 25 years old and I can't possibly have an age-related issue. I mean, that's an exact quote, Lori. That's an exact quote. And he explained that he goes, Jill, I saw this happening last year. That's why I prescribed it for you. And then he explained that the urethra is kind of like the canary in the coal mine for estrogen atrophy. It's the first part of the urinary tract to start screaming when it gets dry. Because here's the issue. Think about the job of the bladder and the urethra. It's to hold toxic waste. Urine contains ammonia and urea and all sorts of bad things. So how can the bladder hold ammonia for hours at a time and not get damaged? It's a real evolutionary marvel, because it turns out the way the bladder and urethra and vulva and the vagina protect themselves is with a really thick coating of mucus. They're like your mouth. They're hollow organs that are wet and slippery on the inside. And the purpose of that mucus is to be a barrier. It's thick, it's robust, it's hydrophobic. It pushes urine away from the skin. Okay? So the quality and health of your skin, that mucus is essential to its health. So here's the problem. Mucus production is estrogen dependent. What does that mean? When you're young and have a lot of estrogen, your bladder can make a lot of mucus. The skin can make a lot of mucus. But if you're on birth control, if you're on Lupron for endometriosis, if you're on estrogen suppression medications for cancer, or you're 52 years old, you are now in estrogen atrophy, which means your bladder and your urethra does not have enough estrogen to make mucus. So what my urologist, Dr. Mark Klein, love him dearly, said is, I want you to rub a pea-sized drop of estrogen cream into the entrance of your urethra. Now, interestingly, I had an appointment with my gynecologist the very next day. Love him too, Dr. David Bennett. They're both retired now. And so I went into that appointment like, all right, can you help me here? Can you please help me? Saw the urologist yesterday. He thinks it's estrogen atrophy. Would you please look and tell me what you think? And he looked and he goes, yeah, he's right. It's estrogen atrophy. And I went, do you agree with using the estrogen cream? He goes, absolutely. I want you to rub a pea-sized drop into the entrance of your urethra. And he's the one who set me up with the women's international pharmacy. He said, I'm not giving you brand name estrogen. We're going to go for the good stuff. So he switched the prescription from like Estrace over to this compounded preservative-free formula. Within 2 weeks, it was gone, honey. That same thing, Anne says, what if you have vaginal burning? Same thing. It can be estrogen atrophy. It happened to me at the age of 51, 52. Another symptom of estrogen atrophy is your urine feels hot. like it's burning you as it's coming out of you. We call it urine burn. That's estrogen atrophy on the vulva. So the name of this condition, this is not interstitial cystitis. This is called the genitourinary syndrome of menopause, also known as GSM. It happens to millions of women. And one of the best things you can do, now estrogen is the most natural thing you can do, because when you give the skin estrogen, it makes your own natural mucus. And so if your doctor hasn't given you topical estrogen yet, that's something you want to have a conversation with. But the other thing, let me get it. Hold on. Let me get it. Vulva Balm is phenomenal for reducing burning on the outside. So Vulva Balm is an organic olive, sea buckthorn, and avocado oil that mimics your own natural mucus. Your mucus is oil anyway. It's hydrophobic. It's not water soluble. It pushes urine, it pushes water away. Your own natural mucus has a light oil base. So water or KY is not going to give you the protection you need. It needs a slight oil base. This is one of the best things that we have. I use it myself. This is my personal bottle of Vulva Balm that is in my bathroom. Let me show it to you so you can see. It's a very light oil, and it's just super, super, super light. It is as close to your own natural mucus as you'll ever find in a natural product. It's fabulous. It's called, here it is it's in the IC Network shop, Vulva Balm by Medicine Mama. And I know for you guys on YouTube, for you guys on Instagram, it's backwards. Vulva Balm, BALM. This is great. I use it myself. And I start feeling it. Now, I'm not in a relationship, right? I'm not in a sexual relationship right now. And I've had a hysterectomy. I've had a double mastectomy. I am 65 years old and I am dry, my friends. I am dry. But I use my estrogen, and that helps my skin tremendously. And if I ever feel where I will feel that dryness sometimes the most is right at the entrance to my vagina and the vaginal introitus. And man, as soon as I feel that prickle, man, I just grab my Vulva Balm, put it on, goes away right away. It's not a numbing agent, it's a protective agent. So Vulva Balm, cannot go wrong with that. I've never had it returned ever in the IC Network shop. Guys, we have a store. So, we have our main website, which is the largest archive of IC information in the world. How do we pay for that website? Is we have a store. And in our store, we have the best books, like IC 101 is not just a bladder disease. We've got, where's my other favorite book? All-time favorite book of all, Breaking Through Chronic Pelvic Pain by Dr. Jerome Weiss. Who is that? So you can get lots of books. We're expanding our IC 101 book series. Our guide to managing flares, or the flare guide, is now available as a PDF. We'll have the print one next week. And then we're moving on to our new diet guide. And then we're going to do a new medical journal, which is already down on my floor. And then we'll have a pain guide. Okay. So our IC 101 book series is increasing dramatically. should be done with all of them by the end of the year. Lori says, does GSM cause frequency as well? Yes, absolutely. The reason why it causes frequency is because your bladder does not have the mucus that normally protects the nerves. It doesn't. And so that cup of coffee you used to be able to drink in your 30s and 40s, all of a sudden in your 50s start hurt. And the reason it hurts is because your bladder can't defend itself like it used to be able to defend itself, because it doesn't have enough mucus, because you don't have enough estrogen to make the mucus. John also gets urine burn. Where, John? Where do you get the urine burn? So urine burn can also happen with chemical exposures, chemical irritation on the skin, abrasion, biomechanical influences, where the skin is subjected to some sort of stress down there, like sitting on a bicycle seat, sitting in a chair for a long period of time. You get pain in your urethra. Yeah, definitely. So the question then is, does your urine burn is not going to be caused by a loss of estrogen. Your urine burn is more likely caused by tight pelvic floor muscles combined with prostate stuff. And I have an email for you from Dr. Evans. Okay, so we should talk. All right, what am I missing here? Donna says she loves the balm. Denise says, you use estrogen every day. Not usually. It depends upon how atrophied your skin is. In many cases, a doctor might say, I want you to use it every day for 2 weeks. And that's just to saturate the skin and get things moving. And then you kind of drop down to 2 or 3 times a week after that. That's quite common and normal. Donna uses date syrup in her Dandy Blend. Interesting. I've never seen dates. That's very interesting. All right, what am I missing here? Lori says, could urine burn be from eating or drinking acidic stuff? Yeah, absolutely. But the burning is happening because the acid is damaging the skin or irritating the skin. So there's a two-pronged process happening here. The quality and health of your skin. Listen, if you got a ton of estrogen and you got a ton of mucus, you're going to be able to, your skin is going to be able to defend itself from cranberry juice and coffee and soda. But if you're of a certain age and you're now losing that protection, your skin cannot defend itself as well. So then drinking acid stuff is potentially riskier. So it's not just the chemical from what you're drinking. It's the fact that your skin is compromised in the first place by loss of estrogen. Lori said, my urogyne wants to do a hydrodistension in November. I'm hesitant because of the bladder installations not working. Well, Lori, a hydrodistension has 2 purposes. A hydrodistension is diagnostic. It allows them to take a closer look at your bladder wall, and you've been in a lot of pain, honey. And so, I mean, I don't like doctors guessing. I want facts. If I'm in pain, I want them to look at it and tell me if there's a problem with what they're seeing. So I am not opposed to doing a hydrodistension cystoscopy at all. I think it's important that, they could do a plain cysto in the doctor's office to get a brief look that does not involve stretching the bladder with water, or they can do a hydrodistension with cystoscopy, and that is to stretch the bladder with water or fluid and then get a closer look at the bladder wall with better equipment. So if I'm scared and I'm in pain, I definitely want somebody to look. I mean, I've had 3 cystoscopies and 1 hydrodistension, and if my doctor wanted to do a cysto, I'd say, "Yeah, let's do it right now." I'd do it on camera for you. I'm not worried about that at all. Lori said she's already had cystoscopy. What did it find? What did they see when they looked in your bladder the first time? Now, the second thing that a hydrodistension can do is that it can be therapeutic in the sense that when you stretch the bladder, you break the nerves in the bladder wall. I mean, it's stretching the bladder wall to the point that the nerves break. And when the nerves break, they cannot send messages. They become deadened nerves. And so all of a sudden, after you get through your post-op recovery for a couple of days, you feel much, much better. There's no pain. There's not a lot of frequency urgency because the nerves are broken. But the nerves always grow back. And the problem is more nerves grow back sometimes than you originally had. So a hydrodistension with cystoscopy is what I call a destructive therapy. It works because it's damaging. It's not a constructive therapy. It doesn't work because it's making something happen, like your bladder wall, helping your bladder wall heal. It's working because it breaks things. So, as a long-term strategy, hydrodistension therapies are really not done so much anymore because now we have phenotyping. Now we can do a deeper dive into trying to figure out why your symptoms are happening in the first place. 20, 30 years ago, lots of people had hydrodistensions. Not so much anymore. Hydrodistensions are again, I'm not going to say they're discouraged. I'm just saying that they're not rampantly used anymore. Of course, the next question you have to ask is how will they do the hydrodistension? In the old days, they did what we call a high pressure, long duration hydrodistension. What that means is that it was a lot of water under a lot of pressure to really stretch the tissue. But the flaw with doing high pressure techniques is that you can rupture the bladder. Like if anybody out there has ever had a hydrodistension and they sent you home with a catheter, your bladder was broken. Your bladder was ruptured. Okay. And you have to have the catheter for a week while it heals. So our guidelines, since they were first released in 2011, have said no more high pressure, long duration hydrodistension. We're trying to minimize bladder wall damage. We want to be as gentle as we can to the bladder wall. So today, hydrodistensions are supposed to be low pressure, short duration. So a little bit of pressure for a very brief period of time to just let them get a look in the bladder. So I would want to make sure that they're not going to do a high pressure procedure, Lori. Just ask them, you're going to do low pressure AUA guidelines or high pressure? If that doctor says, don't tell me what to do, I'm going to do it my way, I would back away. That's not an acceptable answer. The way I would counter that is I would say, listen, I'm all for you looking in my bladder, helping me figure this out. I just want you to be as gentle as you can possibly be. I want to minimize trauma to this tissue. I have done my research. I have read the guidelines. I see that these are supposed to be low pressure, short duration, and I'm hoping that you will be using that. And the vast majority of urologists would say, absolutely, I don't want to damage your bladder either. But if you have a doctor who said, don't tell me what to do, I'm going to do whatever the way I want to, I would be a little bit concerned about that. You know, this follows the rule of don't let anybody put anything in your bladder without telling you what it is first. And for God's sake, write it down. You cannot just, if a doctor says, hey, we're going to do a bladder treatment, you're going to say, great, what is it? It's just a bladder treatment. Like, no, I kind of want a little bit more information. It's going to be a heparin, heparin lidocaine, GMSO, silver nitrate. What are you going to do? Because our guidelines say it is a doctor's responsibility to get your buy-in by talking about the benefits versus risks. So this is not about trusting your doctor. I don't care what you do, just do anything to make it go away. That's not good enough. You got to be an active participant in your care here. You got to know what they're putting in. There's nothing more frustrating for me working with patients who don't know what their treatment was. It's like, wait, you let them put something in your bladder and you don't know what it is? Yeah. No, that's not good enough. Don't ever do that again. Write it down. How are we going to know if it's working? Lori says, your weekly program is such an incredible IC information offering. Thank you, Jill. I am always learning from you. I'm reminded not to get too happy about my on the edge remission. If it feels good, I get a bit lazy about taking my pre-leaf or my bladder supplement. As my bladder feels just fine. And then my bladder shoots me a little reminder, tending to my tissues and my lining. I apologize. Oh, honey, you're good. I'm the same way about my pelvic floor. I can be pretty passive about my pelvic floor, and then I start getting rectal pain, and then I start getting pain when I sit, and then it gets vibrating, and then it's like, okay, you got to work on it. Donna says, the summer fall icy optimist is excellent. Thank you. Thank you. Thank you. The reason why it's a summer fall issue is that my typesetter Julie, her husband almost died. And he'd been in the hospital for months and months. We're just trying to save his life. They're very, very dear friends of mine. And so I had to, I mean, this was ready to go like the middle of July, but she couldn't get to it until late August. And so I just added 3 more articles to it. We made it a joint issue. I try to do 4 issues a year, but 3 is quite common also. Just know that I try to make it right. If you become a member, it's $25 a year to get to read it online. It's $50 a year if you want me to mail it to you. You will always get 4 issues. And usually you're going to get 6 issues, even if you cancel. I always try to make it right and make that worth your money. Donna says GLX 100 sounds incredible. Yeah, that's the new bladder installation that they're studying in Australia. All right, Melly says, this has been going on for so long. I wish there was a cure for us. Okay, Melly, I love this question because I'm going to push back on you just a little bit. You don't cure an injury, you heal an injury. So the question then becomes, is IC a disease or is IC an injury? Now, 20 years ago, 25 years ago, we all thought that IC was an incurable bladder disease. We don't think that anymore. We don't. And the number of IC patients who actually have a disease is like this small, like 5 to 10%. For the rest of us, it really is injury. So this is why we do phenotyping. Because when we apply phenotypes to a patient, we can identify underlying causation and try to find the correct treatment for your unique case. So our phenotyping, now everybody in the world now is phenotyping. All the top researchers, the top doctors are doing this. In fact, our book, IC 101, which came out 5 years ago, was the first book that introduced phenotyping. It's still the only book written that talks about phenotyping for IC patients because that is the future. Absolutely, 100%. We know that bladder treatments don't work for the vast majority of patients. Why? We also know that the great majority of patients have normal bladders. So if my bladder is normal on the inside And bladder therapy has never worked for me. Do I have a bladder disease? No. In my case, and that was me, my problem was being driven by very tight pelvic floor muscle. So let's go over the phenotypes real quick. Phenotype number 1, Hunner's lesions, Hunner's ulcers. That's the disease for the most part. For some of you, not all of you. Hunner's lesions are visible wounds on the bladder, and I have pictures here, and I love showing pictures. So let's look at some pictures here. Here we go. Okay. My file got wet, so my pictures are kind of crinkly now. So I want to give you the best picture. Okay. Okay. So in the old days, 10 years ago or more, we thought this was IC. Okay, so what is this? These are petechial hemorrhaging. You can see dots, red dots. Okay. So petechial hemorrhaging was first described back when they invented a cystoscope. Actually, a little bit past that. When they started doing bladder distensions and stretching the bladders, that's when they started seeing these. And they started seeing these in lots of IC patients. So they assumed, maybe that's this mysterious bladder disease. This is now completely thrown out. This is not a bladder disease process. This is what happens when you stretch the bladder. So in 1987, when our IC research guidelines came out, they said for an IC patient to be put into a research study, they had to have Hunner's lesions or petechiae. These are petechiae. And then, like literally a year later, another researcher did a research study to prove this was wrong. He took 50 women, scheduled for tubal ligation, no history of urinary issues, did a hydrodistension with cystoscopy, and had this happen in every patient. And so he proved that this is not unique to IC. This is what happens when you stretch the bladder. So our new guidelines are 2022 updated guidelines. Just these are now thrown out as not being meaningful. Okay, so this is not a disease. This is really a legacy of doing a hydrodistension. Okay, so what's a Hunner's lesion? I need to print these out again. We have this atlas now, this published atlas of lesions. So look at how different this is. Okay, these are Hunner's lesions. And Hunner's lesions are characterized. This is a perfect Hunner's lesion right here. They have a big center red spot, often with arms radiating out. You can see that? This is called a stellate appearance. So there's a center of the lesion, and that inflammation can spread. So we're going to look at this, and we're going to look at this. Ginormous difference. Okay. So these are lesions, and then lesions have what they call a coagulum, which is that center point. And then lesions, these are lesions without that center point. I mean, they look bloody awful, don't they? And then these are lesions down here that have healed. You can see, so you can still see that center point, but there's a lot of white around it. Okay. So now the question is, what causes a lesion? Why would this happen in the first place? Well, I mean, this is considered one of the big mysteries of IC. Why do lesions occur? It was researchers in Europe who, about 10, 12 years ago, started comparing the urine of patients with lesions and the urine of patients without lesions. And they found something. What they found was a virus, a viral infection of the bladder wall. And we have long known that viruses can infect the bladder. And we have long known that viruses that infect the bladder cause horrific bleeding and wounding. So the virus they found was the Epstein-Barr virus and the polyoma BK virus. So anyway, Europe produced a bunch of studies. I don't know. Oh, you know why my hair is pulling? My hair is being all weird, but it's pulling on the back of my chair. Okay. So here we've got all these studies from Europe, and the Americans are like quiet. It's like, we were talking about, you could go back and watch these meetings. It's like, okay, America, National Institutes of Health, what do you think of the viral finding? I mean, because if there's a virus, we can treat it with an antiviral, right? So they were quiet for 5 years. What we didn't know is they were doing their own viral study because the MAP Research Network had all these urine samples from a couple hundred patients over time. So they went back and looked at the urine samples. And you know what they found? Virus in about 5% of IC patients. Same viruses. So concept number one here is that some Hunner's lesions are caused by viral infections, and Epstein-Barr is very common. I was working with a patient last week who is in her 60s, and her Epstein-Barr came back last year, and she's very high on Epstein-Barr testing, and her urinary symptoms are off the charts right now. They're really bad. The other theory about what causes Hunner's lesions is not a theory anymore. We also now know that when nerves are inflamed, they release a toxic substance called substance P, which can also cause lesions. So neuroinflammation, and now we have an origin for that, is called posterior fornix syndrome. It's a damaged ligament. You have a ligament for women. Men have the same ligament. It's a ligament around, what is it called? The uterosacral ligament, and men have a similar ligament. What makes this ligament really, really important is that when the nerves come out of the bladder and go up to the sacrum, they have structural support. The ligament holds the nerves in place. So if the ligament is damaged or the ligament is stretched out, the nerves become stretched out. And then the nerves become very inflamed, and then they start releasing bad things and start causing urinary symptoms. This is called posterior fornix syndrome. So we had a fantastic case study of a woman who had severe Hunner's lesions. She had a severe prolapse. They went in surgically to repair the prolapse. Her uterus was backwards. The front of her uterus was facing backwards, and the back of her uterus was facing front because the ligament was broken. So her uterus was free swinging on one ligament, and her uterus literally had twisted out of place. So what did they do? They restored it surgically. They untwisted it, restored it. After surgery, her Hunner's lesions healed completely. She's considered a complete and total cure. And it's interesting, posterior fornix syndrome was discovered in 1991. They just this year proposed posterior fornix syndrome as a new phenotype for IC, and I agree with that. Any patient with lesions needs to be assessed for this damaged ligament and these damaged nerves, because they can fix that. So that doesn't get cured, that gets healed. Melly, this is a long answer to your question. I don't know if you're still here or not, but I'm getting there, girl. Okay, So phenotype number 1, Hunner's lesions. Phenotype number 2, bladder wall driven. First thing we're going to look for is a chemical injury to the bladder. So these are the patients whose symptoms began while they're going through chemotherapy, or if they're drinking a lot of Mountain Dew and stuff like that, or they've got industrial exposures. That's an injury to the bladder wall. We're going to get rid of the thing that's irritating it, and the bladder should heal. The next thing we're going to look at is estrogen atrophy. Aging and estrogen atrophy is not a disease. We don't cure that disease. We have to give the body what it needs to compensate for losing estrogen. So again, there's no cure for that. That's about healing tissue and supplementing tissue and improving skin health. Our largest phenotype is pelvic floor driven. Pelvic floor driven. 85% of IC patients, 85% of IC patients have tight pelvic floor muscles, which is why now the great majority of doctors consider this a neuromuscular disorder. The single most important diagnostic test is actually the pelvic floor assessment. And in our national guidelines for IC now only have 2 recommendations. Everything else is option. Recommendation number 1 is if a patient has Hunner's lesions, treat them. Recommendation number 2, if a patient has tight muscles, you send them immediately to physical therapy. All the other treatments, InterStim, Botox, those are options. They're not recommended anymore. Physical therapy helps the vast majority of patients who do it, including me. So again, then our question is, why are the muscles tight? It's usually injury, but it can be other things too. There are other things that can go on. And this is, there's always exceptions, like somebody with endometriosis on their bladder, or somebody with fibroid tumor, or somebody with a back injury. But those are small. These are the most common. Our next phenotype is pudendal neuralgia. These are patients who have pain when they sit down that gets better when they stand up. Hi there. Okay. So if you have pain when you sit down that gets better when you stand up, or if you have pain when you bend over, or your pain is related to the position of your body. So one of the questions that I ask patients to help understand this is, do you have pain when you try to sleep? So do you have pain on your left side? Does it get better when you move over to your right side? Does it get better when you lay on your back, or vice versa? That's definitely body position. That's all about structures and how structures are moving in certain body positions. So pain when you sit down that gets better when you stand up, that's a muscle squeezing a nerve, my friend. So our treatment for that is going to be physical therapy combined with nerve calming therapies and treatments, whether it's going to be a nerve block or it's going to be something simple like Peora, which can calm nerves down. And then our last phenotype is the most interesting. That's our biggest change really in the last couple of years has been the identification of patients who have widespread pain, chronic overlapping pain conditions. So these are patients who might have IC, they might have IBS, vulvodynia, TMJ, migraines, fibro, etc. These patients have very sensitive skin and a wicked sense of smell. We can smell things that other people can't smell, and smells drive us crazy. I have found more gas leaks in my neighborhood. I've found so many of them that I was offered a job by our gas company. They're like, how the hell do you smell this? This is the tiniest gas. The last one was coming out of our street like 3 or 4 years ago. I smelled it. I found it. I called. They sent the fire department. The fire department went, well, we don't smell anything. Sent the gas company out, put the meter down. Oh, yeah, there's a gas leak here for sure. So why would an IC patient have sensory sensitivity? Eyesight, hearing, smell, taste, touch. Well, and when you're the patient, you're just so confused. It's like, I had vulvodynia and I had frequency urgency in junior high. I had vulvodynia in high school. I had severe IBS in my 20s, got migraines in my 20s, got bladder pain for the first time in my early 30s. And in my 20s, I got all this crazy sensitivity and I had terrible anxiety, just really bad anxiety disorder. So, again, about 10 years ago, a fabulous research team came together called the Chronic Pain Research Alliance. And their job was to try to figure out why this happened to some people, but not everybody. Because it happened to me. And I did not have a normal life. I mean, I just like every year it was something new. And when you're the patient, you're so lonely and you're so depressed and you're so frustrated because you're watching everybody living their lives and you're at home. Man, you're just at home watching. The world is watching by as you're in the bathroom or miserable or whatever, whether it's migraines or IC or whatever. So this research team started studying our nervous system because the connection between all these obviously is nerves, right? So they started studying nerves on our skin. One of the things they found is that we have something called small fiber polyneuropathy, which I definitely have. Very sensitive nerves and the tiniest nerves in your skin. So feeling like you're getting poked by pins, that's one of the symptoms of small fiber polyneuropathy. They started studying the nerves of the spinal cord. It's like, are they different? And then they started studying the brain. Now, this is going to sound scary, but it's not scary. And there's a very happy ending here, okay? But here's what they found. Patients with widespread pain are living 24 hours a day, 7 days a week in fight or flight. The 24 hours a day, our brain is behaving as if our life is at stake at this very moment. Now, fight or flight is supposed to be short term. If you open your front door and you see a saber-tooth tiger, hello, you're going to go into fight or flight. There's no doubt about that. This is an animalistic response to a predator. But you shut the door, you call the authorities, they come out, they trank the tiger, an hour or 2 hours later, the tiger's gone, the threat is gone, and the parasympathetic nervous system is supposed to take back control of the brain. Fight or flight, the sympathetic nervous system raises your heart rate, raises your blood pressure, tightens your muscle to prepare you to fight, flee, or freeze. Okay, so fight or flight is about preparing your brain to respond to a predator. When the threat is gone, the parasympathetic nervous system retakes control of your central nervous system, and it lowers your heart rate, and it lowers your blood pressure, and it relaxes your muscles. We are supposed to be controlled most of the day by our parasympathetic nervous system. But patients with widespread pain are stuck in the on fight or flight position. And they can see it in the brain. The amygdala, which is the command and control center of fight or flight, has total control of the brain. Okay. So why does this happen? I wanted to know why. Why me? Why? What research shows is that for 80% of the children who grow up to develop widespread pain as adults, there is a major physical injury in childhood. So I can still remember I was working with a woman in her 50s who was diagnosed with IC, really suffering, but she had all the widespread pain conditions like me. She was my sister easily. And she had suffered a broken back when she was in high school, and her mother did not believe her and sent her to school for 3 weeks with a badly broken back. It takes 14 days of pain to put the brain into a constant state of fight or flight. So I've worked with patients a lot of patients hit by cars, or, broken bones, things like that, falling downstairs, falling out of trees, things like that. Now, for the other 20%, it's a history of abuse or bullying. The most common theme in my office are children who grow up in the homes of abusive alcoholic parents that Every day when that child is at home, they are in fight or flight, watching mom or dad drinking and waiting for them to get violent. You got to understand the brainstem where this all happens. There's no cognition happening here. Your brainstem has one job, and that is to save your life. It is monitoring your sensory input 24 hours a day, looking for threat. What do you hear? Is it somebody screaming, or is it your favorite music? What do you see? Is it a tiger or is it a puppy? Okay, so that brainstem has been trained through trauma to become very, very hypervigilant. So I had a patient call who shared how violent her home was, that she would lock herself and her younger brother when they were very small kids in the bathroom. She was trying to save her brother because when dad started drinking, he got violent and he'd break down the door and beat him up anyway. And she was badly traumatized by that. And the other thing that's just so interesting is when you work with patients and you start asking about family members, other family members also have these related conditions. Some might have a migraine, others might have this or that. The foundation for all of that is childhood trauma. The good news here, and I have shared what my childhood trauma was, that I grew up in a neighborhood with a kid my age who became a rapist and murderer. A year I went away to college, he raped and murdered my neighbor and tried to murder her boyfriend at the time, her fiance, actually. At least I think it was her fiance. I think it was. So think about what my brain did. My safe place was my home. But as soon as my mom or my dad woke me up to go to school, you got to get up, you got to get up, you got to get up in the morning. That's how my dad would sing me awake. I went into fight or flight. And then this was back in the day when we all walked to school. So I didn't just walk to school, I ran to school as fast as I could, always looking behind me because I never knew when I was going to get attacked. And then when I got to school, I was the extreme of hypervigilance because I never knew where he was. And he hurt a lot of people, not just me, a lot of people. And then when school was out, that was the worst because I had to run home up a hill as fast as I could because that's when I was attacked. So I lived in fight or flight from 4th grade through the age of 35. And thankfully, at the age of and guys, listen, I got a bunch of college degrees, including a master in psych, and the master's in psych did not get rid of this for me like I was hoping it would. I still had horrific anxiety. I got my degree when I was 28. I had horrific anxiety. We just never got to the bottom of why all this was happening until much more recently. That it's how a child's brain responds to persistent trauma. And the good news here is we can fix it. At the age of 35, I took a class that taught me how to turn off fight or flight. And it was mind-blowing. It was so cool to go to this class. You know, I went to this class. I signed up for an anxiety management class because I was having panic attacks before every damn doctor's appointment. I'd be in my backyard crying and walking around, and I would get there, but I'd be absolutely miserable, right? And so just one day, I'm just like, oh my God, I'm so sick of this. Clearly, I'm missing something. And I took a class that completely changed my life. And so the first revelation happened just in the first 5 minutes when we all got to meet each other. Because what I saw, I mean, I always thought that I was just a very abnormal, dysfunctional person until I met other patients. And then I was like, oh, wait, that happened to you too? I saw that we were all completely normal people who'd had something bad happen to us. That's all. Didn't say anything about us as a person. We'd just been through trauma. And the instructor was like, all right, how many of you say no to every invitation? Hey, Jill, you want it? No. You want to go? No. You want to go take a drink? No. But I wanted to literally accept every invitation I received. And I will tell you, for probably 20 years, I said no to every invitation. Before they could even finish it, my mouth said no. Why? He goes, you know what that is? And we all looked at each other. How many of you say no? Everybody looked at each other. Oh, you too? Wow, everybody does that. Like, do you know what that is? Like, no. He goes, that's the guarding response. That's your brain trying to keep you safe because you are in fight or flight. You are in fight or flight. This is normal after trauma to say no. And I realized that I did not understand how profoundly my life was affected by this. But now when I go back and I look, hi there, I look at the decisions I've made in my life, they were all tempered by fight or flight. I had a lot of opportunities that I did not take because my brain said, stay home. That's even in the IC world. I mean, I've had offers to fly around the world to go talk about IC, and I used to say no to all of them. And I still say no to a lot of them, for different reasons. But I really grieve the lost opportunities I had because my brain said, I want you to be safe. I want you to stay home. The other thing that happens is as we get older, we tend to get smarter. And it's like, so we can recognize fight or flight. I can say, I'm not God. I can't predict the future. For all I know, tomorrow's going to be a great day. And so your brain goes, oh, well, if that's not good enough, I'm going to exaggerate. Hey, Jill, no, you can't go take that drive because you're going to be in a terrible accident and you're going to get paralyzed. That's called catastrophizing. That's a huge part of being stuck in fight or flight. So the class taught us that the way you bring it all down is by bringing down the adrenaline. We get stuck in this vicious cycle of saying no, catastrophizing. Every time you have a negative thought, you get a jolt of adrenaline, which brings you right back into more fight or flight. So it's like negative thought, fight or flight, negative thought, fight or flight. And we don't just have one negative thought a day. Man, if you got anxiety disorder, you're having hundreds of negative thoughts a day. That's hundreds of shots of adrenaline. And so, the instructor of the class was just phenomenal. And he taught us a technique to bring it all down. When you have and it's all about bringing the adrenaline. If we can just get you out of adrenaline overdosing, because everybody is overdosing with adrenaline. There's just a massive amount of adrenaline shooting through their body because of all these negative thoughts. And so the technique that he taught us is when you have a negative thought, just close your eyes, visualize the stop sign, just stop it. I don't want to listen to your damn negative thoughts. Stop. Then you take a single deep breath. You go in for 3 and out for 3. And that one deep breath, that oxygen has now rendered that adrenaline from that negative thought chemically neutral. It's done. It's over. It will not build up in your bloodstream. And then you just have to remind yourself, what is that? Oh, that weird bug. It's just a negative thought. It has absolutely no power. It's just your brain guarding. So what I say is, oh my God, Jill, you're not God. Tomorrow's going to be a great day. That's just your brain. It has no power. It's just a thought. Stop sign, deep breath, minimize the thought. And he said, okay, all I want to do in this first week is just bring your adrenaline level down. Can you just, as you leave for this next week, could you just do that every time you have a negative thought? Just do it. All we're doing is getting rid of all the adrenaline. Chemistry makes total sense. I had my first negative thought out of the room going, oh my God, this is stupid. It'll never work. But I did it. I did it. That first day, I did it at least 100 times. That second day, I did it about 50 times. That third day, I did it about 20 times. 5 days later, once, my friends, once. That was the first time I had been out of fight or flight since I was attacked in 4th grade. And it was mind-blowing how good I felt. It's like, oh, this is the way I'm supposed to feel. I feel relaxed. I feel comfortable. Just getting rid of all that adrenaline. Anyway, I have a video on that in our IC Living with IC video series that talks a little bit more about what I learned in that class. And that's what I do, guys. Negative thoughts are the enemy. Every day I have one negative thought, although it hasn't happened yet today. I always have one negative thought a day about a damn earthquake. Do not ask me why. Today, the day the earthquake's going to hit. I live in California. I don't know why my brain does that, but it does that. If I have two negative thoughts, stop sign, deep breath, minimize the thought, man. I am not letting this adrenaline build up. It's really rare that I have three, but if I have three, I double down and I do it twice because I know that that's what's going to drive all of this. It's just living in that scary place. And that's why your sense of safety is so important. You have to feel safe. I want you to feel safe. And that's why the internet is failing all of us because it's bringing fear into our homes. It's bringing fear into our consciousness. We have to feel safe and secure. You're not going to do that if you're reading the internet all day. All these companies are making money by keeping you upset. That's going to drive all of this. Like, turn the damn thing off, get outside in the sun and go take a walk and talk with real people. Don't just sit here and watch videos and watch political stuff. It will never get you where you need to go. Donna says, I agree with Jill. I was diagnosed with IC 4 years ago and I've worked really hard to follow the treatment protocols. It has made such a difference. Excellent. All right, we have been going now for 3 hours and 13 minutes. Lisa here on YouTube, and I'm not sure. All right. Can you take P-leaf along with pre-leaf? Sure, because they're not the same. They do different things. And there's no known drug interactions with PEA. I mean, I always say go very slow, take a little bit. You know, I don't believe in, I'm not a more is more kind of person. I'm a less is less kind of person when it comes to treatments and supplements. I don't like the idea of adding more and more and more. I look for finding the lowest effective dose. So pre-leaf you only take with food. And that's only if you're going to be eating food, which is acidic. So you shouldn't be eating pre-leaf like candy. It doesn't work that way. It doesn't change your bladder at all. It just reduces acid levels. So save your pre-leaf for those moments when you're going to eat something risky. Now, P-leaf is very different. P-leaf acts to calm nerves down. That is something that you can take every day. But the nice thing about Peora and P-leaf and palmitoyl ethanolamide is it's what we call durable. In research studies, what that means is that when you stop the medication or the supplement, the benefits continue for a reasonably long period of time. So I don't take Peora every day. I will do a bottle and then I will, or maybe 6 weeks, usually until I run out of a bottle. I'm getting close again. And then I stop it. I stop it for a couple of weeks or longer. The longest I've gone is 6 weeks. And then as soon as I feel my skin getting a little prickly again, then I know it's time to go back on it. So PEA is a kind of a best case scenario for supplements because the benefits are long-term benefits. Chris says, what is the name of the video to find that? Can I repeat the steps again? So just one deep breath, honey. So the technique is real easy. When you have a negative thought, just close your eyes and just visualize a bright red stop sign. Just stop. I don't want to hear it. Just stop. Then you take one deep breath. Just go in for 3 and out for 3. And then minimize the thought. Just minimize it. It's like it's a thought. It has no power. It's just my brain guarding me. And my brain is doing a really good job of exaggerating right now. It's not real, you know? Stop sign, deep breath, minimize the thought. Chris says, Pure the same as PEA 500? Yes, they're the same thing. And the video here, I can get you the link. So somebody asked this on Facebook. For those of you who came into Instagram, we're streaming on 3 platforms. So when I'm looking here, I'm looking at Instagram. When I'm looking here, I'm looking at Facebook. No, I'm looking at YouTube. And when I'm looking here, I'm looking at Facebook. Chris said, would it help with nerve? Yes, it could. It's worth a shot. And what the research shows that it works by calming nerves down. So let me give you, I have a bunch of videos on YouTube. I mean, like 500 videos. But the anxiety video is here. You can tell that through 20 years, I look like a young lady when I started these videos, and now I am a wee bit on the old side, my friend. Hold on, I'm looking for it. Here it is. So it's in our Living with IC video series, and it's an old video. I mean, Melly, it's not, they don't even compare. Aloe does nothing. There is not a single published study showing that aloe is helpful for IC. PEA, I've got an outstanding study with PEA showing that 87% reported a significant progressive reduction in pain. Aloe is soothing. Aloe is soothing to the skin. You would put it on a sunburn. So the only role for aloe in IC is if you have a bladder wall flare. But aloe doesn't fix anything because the bladder is not made of plant material. It's not. So aloe got very popular 20 years ago because it's all we had back then. But we have a lot more insight now into IC. Now we know the phenotypes. Now we know underlying issues. So the role for aloe is now very, very small. So if you are an estrogen atrophy patient, you would be doing a chondroitin-based supplement because chondroitin coats the bladder. The bladder wall is made of chondroitin. There are other molecules in there, but chondroitin plays a critical role in the superficial integrity of the bladder wall. So if you were an estrogen atrophy patient, then bladder builder, bladder rest, cystoprotect, far more effective than aloe. And I've got the research to back it up. I mean, there's good published research with this. Liquid chondroitin is a treatment for IC throughout most of the world. If you are a widespread pain patient or you just have pain, PEA is the supplement we would consider because PEA physically calms irritated nerves down. And we've got great research behind that too. So you can't compare them at all. We don't recommend aloe hardly at all now. The only time I recommend aloe is for somebody with a bladder wall flare, and that's for very temporary use. Because over the long term, it just doesn't get to the root cause of these underlying issues. If your symptoms are being driven by tight pelvic floor muscles, we don't want you to spend the money on an aloe supplement to soothe the bladder wall. We want you to spend the money on getting physical therapy to fix your muscles. Does that make sense? So apples, oranges, and bananas. And it begins with your phenotype. If you can, I would encourage you to watch episode 4. I'll put a link in here of our masterclass on IC. It's a free video series so that you can learn a little bit more about these phenotypes. I'm just putting the link in there on Facebook. And then if you have questions, feel free to give me a phone call. Hello, Paula. She is from Tenby in Wales. Paula, I was watching this morning on YouTube the stream from Heathrow, watching all the 747s land at Heathrow Airport. There's that great guy who streams from Heathrow, and he's very entertaining. So as I was doing whatever it was I was doing this morning, I had him on for a little bit. And then sometimes I watch the airport videos from Manchester Airport. The reason why we do that is because I have a lot of pilots in my family, and my mother loved watching videos. So I would just put the stream on for her while she was doing her crossword puzzles. She'd be in heaven. So I just got into the habit. I like watching planes. Chris says, what's a max to take a PEA? I got some from you. I have nerve issues with my IC. I would follow the instructions. I mean, like 2 a day. You could potentially go to 3, but I wouldn't be doubling or tripling your dose at all. I mean, the dosage used in a lot of the studies was like 1,000 milligrams a day. If you go to the front page of the IC Network website, I've got a blog on PEA with all the research. And so you can actually click on the research and look at the dosages they were using in the research studies. So anywhere from 400 to 1,000, but not super, super high doses. Okay. So, again, I'm a less is more kind of girl myself. That's what my degree in pharmacology taught me, was finding the lowest effective dose rather than the highest effective dose to minimize adverse events and trauma. All right, guys. Well, listen, thank you, Chris. You're welcome. If you guys find this helpful, please think about becoming a member of the IC Network. You can get our magazine, and that's what keeps me doing these meetings. Times are tough for everybody. I understand that. So it's $25 a year if you read it online. And man, that's a deal. That's a deal. We've been doing this for 23 years. And if there's anybody online who's saying, hey, take my class for $1,000 and I'll teach you how to heal your IC, I call bullshit on that. You watch our free masterclass first, because that's going to teach you a lot. You don't have to pay a lot of money to learn this. Between our IC 101 book and our video series, I'm bringing you the best I can find. I mean, a lot of the stuff you hear in these meetings are what the top IC researchers are doing. Your local doctors are clueless because they don't take the classes and they don't read the research, and they go to meetings. So I'm trying to get your knowledge level up so that you can interact more effectively with them and give them hard, tough questions. So anyway, well, listen, I think we're done. 3.5 hours. So my intention is to be back next week. Knock on wood. And anybody wants to talk to me, you're absolutely welcome to call the IC Network. Just call the 800 video. Chris said, what year is the anxiety video? I don't know. I gave you the link for it. It was an early video, and it hasn't changed. It's perfectly fine. So I'm probably going to look 15 years younger in that video. Let me give you the link again. There you go. Well, I gave you a link before that too. It's okay. All right. All right, my friends. I will see you next week. I hope you're decorating for Halloween. If you love Halloween like I do, bring happiness and joy into your home. Nobody is responsible for your happiness but you. So you got to ask yourself, what would I do? What can I do to be happy? For me, I'm going to, what am I going to do tonight? Friends coming over. We're going to play games. I don't know what we're going to play. If he's here, we're going to play some games. And I've already walked, so I'm not going to walk because I don't want to fall down again. And yeah, I think I'll paint a little bit. So, all right, I'm going to say goodbye to Instagram first. Bye, you guys. Thanks for watching. Definitely have to do Instagram a lot more. Wow, 60 people watched. Love it. Love it. All right. And Facebook, my friends, I will see you guys later. If I can do a drop-in meeting, I will this week. All right. All right. Where is my YouTube? Hello, YouTube. Any last questions over here? Key Hicks says, thank you so much for all the info and support. You are very welcome, my friend. But credibility test me. I'm fallible too. You know, read up. Got to read up. All right, guys. I'll see you later. If I can see around this. Okay.